Uh, dear Professor Tehran. Hello.
Good afternoon. Hello.
Hello, dear Professor. Very nice to meet you.
Yes, same here. It's delightful to see you all.
I should thank you a lot for arranging this session, and I should apologize for a little bit delay in the starting of the session.
No, that's absolutely fine. We are all very happy to be here.
Thank you very much.
Thank you for inviting us.
Thank you very much, Professor. Thank you. We shall be with you in I think 2 minutes. Thank you very much. Thank you.
Thank you. Thank you. Hello, Maya.
Hello, dear Professor. Good evening.
Good evening.
So nice to see you here. Thank you very much for arranging this amazing session for us.
Thank you for calling us. It's a pleasure.
Thank you. Thank you.
I will
start. Thank you. Yeah. I will start in about 3 minutes. Sorry for the delay.
Don't worry. Don't worry.
Thank you. Hello and good afternoon, good evening, good night, and good morning to everyone, all our dear friends and colleagues from all around the world. Today is the fourth day of the amazing 33rd International Congress on Pediatrics, hosted by Tehran University of Medical Sciences at Children's Medical Centers Hospital. I'm Dr. Mahia Qahramanlu, a pediatric resident at Tehran University of Medical Sciences Children's Medical Centers Hospital. Such a great honor for me to be here. I'm so proud to be a part of the amazing executive team of the Congress. Now we are going to have a particular session on difficult anemia. So many thanks to dear Professor Trehan for arranging this session for us, for gathering the best pediatric oncologist, hematologist from her team. And I'm sure that we are going to have a really nice session. Please, dear participants, log in with your real full name in English. And please make sure your microphone is muted, your video is off, and please ask all your questions or send us your comments in the chat section in English. Do not forget to register on our web application in order to receive your certificate of attendance in English. You will receive it within 7 days. And please, again, log in here with your full name in English, because the list of Zoom audiences will be matched with the list of registered applications for certificate of attendance. And all dear Iranian participants will be able to receive their CME credit. So please take the exam at the end of the session on ircme.ir, and let's go on starting our fantastic difficult anemia session. Dear Mariam, I'm ready to start. Hello again and welcome everyone. We will start our hematology session on difficult anemia. Okay, and the first lecture. We're going to have the first lecture with Dr. Deepak Bensal. Dr. Bensal is Professor of Pediatric, Department of Pediatrics, Postgraduate Institute of Medical Education and Research, Chandigarh, India. He received Fellowship of Hematology Oncology degree from Alberta Children's Hospital, Calgary, Canada, 2009. He is member of International Society of Pediatric Oncology, Scientific Program Advisory Committee, Myeloid Leukemia, Myelodysplastic and Myeloproliferative Syndrome, 2018 to 19. Executive Committee member and Chronic Myeloproliferative Disease Group Chair, Indian Pediatric Oncology Group, and also is a member of International Society of Pediatrics Oncology. I think we don't have dear Professor Bensal here with us, so we will start his backup video and hope he will join us soon.
So I'm Deepak Bensal. So the topic that I have to cover today is the magnitude and myriad etiologies of pediatric anemias. I shall try to make it very light so that it's easily grasped. Sorry. Right, so first I'll start with what is the definition of anemia in children. While sitting in the outpatients, one often tends to forget that the hemoglobin can be varied across the age ranges. So this is the WHO definition of the normal hemoglobins and anemia. So if you look at the age range of 6 months to 5 years, which is the most common in which anemia occurs in children, so the normal average hemoglobin is 12 and anemia is defined by WHO as less than 11. From 5 to 12 years, the anemia is less than 11.5. From 12 to 14, it's less than 12. And in the age group of 14 to 19 years, the normal hemoglobin, if you see, is pretty high. For girls, it's 13, and for boys, it's 15 gram%. And the anemia is defined in girls as below 12 and in boys below 13. So often in the outpatients, one tends to think that the hemoglobin of 10, 11, 12 may be normal, but it may be low for that particular age. So there are formulas available to remember this by the age. So if one can use this as well. So there are two terms. One is iron deficiency anemia and one is iron deficiency without anemia. So what is the difference? When the hemoglobin is low, along with a low ferritin, it is iron deficiency with anemia. Whereas iron deficiency is a normal hemoglobin. The hemoglobin is normal here, but the iron stores, that is the ferritin, are low. So there are two terms. It is not just iron deficiency anemia, it's iron deficiency as well as iron deficiency anemia. So why is this important? Because both iron deficiency as well as anemia affect neurodevelopment, growth, and immunity. And in the outpatients, we can see children with all these conditions, and all of them have been associated with iron deficiency, including pica, breath holding spells, febrile seizures, defects in leukocyte function, reduced exercise capacity, and cerebral vein thrombosis, or children presenting with stroke. And iron deficiency anemia, as we know, leads to thrombocytosis, and that can result in strokes. So I'll ask you the next question, a question. At what age should iron supplements be started in a full term, normal birth weight, exclusively breastfed, well baby? So if you get a baby in your clinic who's absolutely well, no concerns, so should you be giving him iron? So the American Academy of Pediatrics says that all normal babies should be started on iron at 4 months of age at a dose of elemental 1 milligram per kilo per day, until appropriate iron-containing complementary foods are introduced in the diet. So this is really important to remember that all normal babies who are breastfed should be on iron from 4 months of age. And this is because low IQ scores have been observed in iron-deficient children even before the development of anemia. So at what age should iron supplements be started in preterm babies? And the answer is 2 weeks of age. And this is the dose, 2 to 4 milligram per kilo per day with a maximum of 15 milligrams. So all preterms at 2 weeks of age. So this is a large systemic review and meta-analysis on the estimation of iron deficiency anemia in Iranian children and adolescents, published in 2017. So the authors looked at 27 studies of iron deficiency anemia in children in Iran. So about 12,000 children below 18 years of age. Most of the studies were from the urban areas. So what did they find? The prevalence of iron deficiency anemia below 6 years of age in Iran is 21%. And if you look at only iron deficiency without anemia, it's 27%. In 6 to 18 years of age, anemia is 10% and iron deficiency is 27%. So what does this mean? It means that below 6 years of age, if you see children in your clinic, about 1/5 of them will have iron deficiency anemia. So in the same study, they found that the highest prevalence of up to 44% were found in these provinces, and a low prevalence of about 10% was found in these provinces of Iran. So the article also states that the Ministry of Health and Medical Education of Iran gives free iron supplements to infants below 2 years of age and to females from 12 to 18 years of age. So the implementation is important, which may not always be great in all low middle income countries. So as a pediatrician, one should try to follow the guidelines of one's own country's governments in a one-to-one everyday practice with the kids that one sees in the outpatient. So what is the prevalence of anemia in children in other countries as compared to Iran? If you look at this, so this is the World Health Organization data. So in USA, so here we are talking at anemia in the age group of 6 months to 5 years of age. USA is 6%, Australia 13%, UK 16%, China 19%. So according to WHO, the prevalence of anemia in the age group of 6 months to 5 years in Iran is 26.5% with this a range which is mentioned. In India, it's as high as 53%. So what is the reason for such a variability? And this is the world map showing the prevalence of anemia, again from the WHO website, age group of 6 months to 5 years. So if you look at the dark brown color, so that is severe, more than 40%, like India, Pakistan, Afghanistan. But if you look at Iran, the prevalence is moderate from 20 to 40%. So why is nutritional anemia much more prevalent in some countries as compared to the Western world? So the answer is the diet that we give to our kids, particularly during infancy. For example, in India and to some extent even in Iran, I think we like to give milk, we like to give rice, and we like to give wheat in some forms or the other to our children. And all these products do not contain enough iron. So if you look at, for example, in India, many people are vegetarian, and several vegetarian foods contain iron as well. And these are listed in the picture here, but it is not always easy to give these foods to infants. And the non-vegetarian foods like eggs, chicken, red meat, and fish really contain a good amount of iron. So provided they are actually given to the infant, which may not be always culturally, religiously acceptable in several parts of the world. So, and there are several foods that we give to our kids, which we can actually reduce the iron absorption, like milk, curd, teas, because they contain phytates and tannins, and again, wheat and pulses, they reduce the absorption of iron. So this is an important slide, and it asks this question: in the age group of 1 to 5 years, what should be the milk consumption? How much it should not be more than ml per day? So if you can think of an answer, so the answer is 600 ml. So any child in the age group of 1 to 5 years should not be getting more than 600 ml of milk. And if it is given, it is likely that the solid food intake will be less, and that will result in iron deficiency anemia. And for kids who are more than a year old, and if they are still bottle fed, it has been shown in studies that discontinuation of bottle will help to reduce milk intake and increase the intake of other foods. So try to avoid bottle feeding above 1 year of age. And this is another study from Iran, which looked at the nutritional habits of mothers and children in the age group of 0 to 4 years. So they did the study in 5 hospitals of Tehran, which were mother and child medical services. They interviewed about 190 mothers and their kids. And below the age of 1 year, they found varying kind of intake of milk, either breast milk alone, with powdered milk, or with cow's milk. The more important thing is that solid food was started after 9 months of age in about 27% children. So this is incorrect, because ideally weaning food should be started at 6 months of age according to the WHO. And if this is not done, this will lead to a higher incidence of iron deficiency anemia. And in anthropometry, they also found that the majority had grade 1 or 2 kids who were undernourished. So it is not that only undernourished kids will have iron deficiency anemia. Iron deficiency actually has got nothing to do with the weight of the child, and the prevalence of iron deficiency has been shown to be even is also there in overweight and obese children for these various reasons, that iron requirement is high, inflammation, and other reasons. So iron deficiency has got nothing to do with the weight of the child. So what is the best preparation for treating iron deficiency anemia in children? And it continues to be ferrous sulfate. It is cheap and best. And although the syrups can have issues of availability and shelf life, the acceptable alternatives to ferrous are fumarate, gluconate, and ascorbate, which are equally good. Although colloidal iron and iron polymaltose complex and other newer fancy ones have lower efficacy. So ferrous sulfate continues to be the cheap and best iron preparation for everyday use. So what should be the dose of iron for treatment of iron deficiency anemia in children? So earlier it used to be 5 or 6, but for the last several years now the elemental dose is 3 milligram per kilo per day, and frequency, giving it once a day is good enough in morning or between meals, because empty stomach the absorption is better. And it has been shown that the efficacy of once daily is as good as 3 times per day. So the answer is 3 milligram per kilo per day, once a day, preferably empty stomach. And the duration is for 2 additional months after the hemoglobin is normal. Typically, at least for 3 months is given for the treatment of iron deficiency anemia. So a question, while receiving iron, child develops the following, either URI or loose stools. What should be done? Should iron be withheld? And the answer is, typically do not stop iron for intercurrent minor ailments, because there is no irrefutable data on harm, but none on benefit either. If you tell the mom that, stop iron for this or that reason, then often iron will get interrupted and may not get restarted, because the mother may associate giving iron with that particular illness. So it's best to tell parents to continue giving iron during minor ailments. What should I inform the parents regarding the GI adverse effects of iron in children? So I would suggest to avoid highlighting GI adverse effects, because recent studies have shown that the GI side effects at 3 milligram per kilo per day are rare, are really rare. So the earlier GI effects that one used to see were at 5 or 6 milligram per kilo per day. And to improve the compliance, the parents can always be told that iron deficiency leads to low IQ scores. So once they hear that, they will definitely be compliant in giving the iron. One should rinse the mouth after giving syrup to avoid teeth stains. And the more important is taking iron regularly is more important than any preparation of the iron. So if one thinks that one is dealing with a case of iron deficiency anemia, but the response is poor, so what could be the reasons? Number one will be continuing excessive milk intake. So if milk is given, iron absorption will be poor. So one has to tell to reduce milk and increase solid intake. Poor compliance, so really ask whether the parents are giving the iron properly or not. Third, celiac disease, I'll come to that. And there could be alternative diagnoses like thalassemia minor, some rare conditions like irida, or hidden sites of blood loss, like in gut or in lungs, in which case one may have to ask for stool occult blood if it is a microstatic hypochromic anemia with low serum ferritin. So how common is celiac disease in Iran? So this is a systemic review and meta-analysis published in 2017. They looked at 63 studies and a large number of participants, and the overall prevalence by serology was 3% and by biopsy diagnosis was 2%. So it's a pretty high prevalence. So that means if you see about 100 kids in your clinic, about 2 of them would have celiac disease. And this prevalence was found to be similar or higher than the worldwide reported. So always think of celiac disease when your child with iron deficiency anemia, that is microstatic hypochromic anemia with low serum ferritin, has a poor response to iron. Ask for the serology to make a diagnosis of celiac disease, which is easy to treat and manage. So is there any role of using parental iron in everyday practice? Very limited role. Response is not more rapid as compared to oral. There are specific indications like inflammatory bowel disease, bowel resection, loss of iron from the skin, heart failure because the mucosa will have edema, rare conditions like irida, and poor tolerability to oral iron is also mentioned as an indication, but it is often an abused indication rather than a real indication. So rarely used, but the preparations which are available are now safe and it can be given easily. So I would also like to talk about delayed cod clamping because it is of extreme epidemiological significance. So all babies who are born now, except minor exceptions, should have delayed umbilical cord clamping, which means the cord should be clamped at least 32 seconds after the birth, even up to 2 to 5 minutes is mentioned in literature, both in term and preterm infants. The advantages, It reduces iron deficiency anemia in infancy and improves the neurodevelopmental outcome. The only kids in which it is not to be done is non-vigorous infants who will require resuscitation. So one can cut the cord and do the needful quickly. So whenever one, as a pediatrician, attends deliveries, one should try to follow delayed umbilical cord clamping to reduce iron deficiency anemia later on in childhood and also to improve the neurodevelopmental outcome. So what about folic acid and vitamin B12 status in Iranian children? So I could not find any specific study, but this is one in Iranian adults, about 1,000 adults healthy. So folate deficiency was found in 1% and low B12 levels in 26%. So many preparations of iron will contain folate and B12 as well, and hopefully it should take care of that. Otherwise, one can look at the MCV. If the MCV is high, then megaloblastic anemia is always suspected. So what is the normal mean corpuscular volume or MCV in children? We all get Coulter reports now of the CBC. So always look at the MCV, and it can be a little hard to remember, but at about 1 year of age, it's about 70 to 90. And at the age of 11 to 14, it goes up to 80 to 90. So approximately, if you need to remember, an MCV of about approximately 80 would be considered as normal. But as you can see, there is a range. One should always try to tell the lab to give a age-specific normative data of the in the report as well, which is useful for interpretation. So two common causes of anemia with low MCV in children. You would all know iron deficiency anemia and a close differential diagnosis of thalassemia, both trade as well as major. So DD of low MCV. So how to diagnose iron deficiency anemia? Hemoglobin will be low, MCV will be low. RDW, look at the RDW in the Coulter report, it will be high, and often the platelet count may be elevated as well in iron deficiency anemia. So do you need to do serum iron studies to diagnose iron deficiency anemia? It depends on the prevalence in your country. If it is high, for Iran, it's about moderate. So typically it is not really necessary if the age is classical and the history is there, dietary, which is suggestive of iron deficiency. So it's not necessary. Therapeutic trial of iron can be easily be used to confirm the diagnosis, and one need not do iron studies in all children, particularly if the age and diet are favoring. So how many among the audience in this meeting have thalassemia minor? So it's a problem which is common both to India and Iran. And the Iran national average of beta thalassemia minor is 4%. So if you have 100 people listening to this talk, about 4 will have thalassemia minor. So in this study, the beta thalassemia, this is a study from Iran, and they have shown that the prevalence of beta thalassemia minor was below 2% in these provinces and more than 8% in these provinces of Iran. So from a CBC report, can I know if it is a thal trait or is it iron deficiency anemia? Because both will have low hemoglobin and low MCV. So always look at the RBC count of the Coulter. RBC count, the normal RBC count is about 4 to 5. In iron deficiency anemia, it will be low. Whereas in beta thalassemia trait, always remember that the RBC count is elevated. Very, very useful clue to make a diagnosis of beta thalassemia trait. Low hemoglobin, low MCV with a raised RBC count because it's a dyserythropoietic anemia. So the RBC count is elevated. So always look at the RBC count to distinguish between beta thalassemia trait and iron deficiency anemia. And how to confirm the diagnosis? It is by hemoglobin A2, which is elevated to more than 3.5% in an HPLC report. And why making a diagnosis of thalassemia minor is important? When both parents have thalassemia minor, there's a 25% risk of birth of thalassemia major in each pregnancy. So every married couple should have thalassemia screening done, and an antenatal diagnosis is now available for several years, and a chorionic villus sampling can be done for 10 to 12 weeks of pregnancy. So the clinical manifestations of beta thalassemia major, we all know typically the kids present beyond 4 to 6 months of age with hepatosplenomegaly, growth failure. Hemolytic phases typically come on later. And how to confirm diagnosis of thalassemia? It is by a simple HPLC investigation, and one looks at the hemoglobin F, which will be elevated. So these are a thalassemia ward. The first one is from India, and this I could get from the internet. It's from Iran. So these patients need lifelong blood transfusion unless a transplant is done. So if you have to remember 3 golden rules for management of beta thalassemia major, the first is always to keep the pre-transfusion hemoglobin more than 9 to 10.5. If you want to remember, about more than 10 gram% prior to a transfusion. Second, to keep the serum ferritin less than 1000, because blood leads to iron accumulation. So one has to give iron chelating drugs to reduce the ferritin. And third, to encourage stem cell transplant at an early age for a permanent cure. So the Iranian Thalassemia Society was launched about more than 30 years ago, and a thalassemia prevention program is ongoing in Iran. And as a result of which the birth rate of beta thalassemia major children has dropped by more than 90% by 2015. And these are the numbers of the various hemoglobinopathies which are there in Iran, various numbers in the various provinces. So the most common is beta thalassemia major, about 16,000 children currently in Iran, which receive transfusion. And sickle cell is also prevalent in Iran, either along with beta thalassemia or by as a homozygous variant. So what role can a pediatrician play in the diagnosis and prevention of thalassemia? Reinforce and encourage at every visit family screening of uncles, aunts, siblings, cousins, as well as encourage antenatal diagnosis. So next is another common problem that we see in outpatients is the hemolytic anemia. So what is a typical triad? It is anemia, jaundice, and splenomegaly. So this is a triad of hemolytic anemia, which one should recognize. And if you have to remember hemolytic anemia in one slide, in all cases of hemolytic anemia, whenever you are suspecting, ask for a good peripheral smear, talk to the pathologist, and ask for a good reticulocyte count. If it is episodic, it is likely to be either G6PD or autoimmune hemolytic anemia. If it is chronic, so first ask yourself, is it acute or is it chronic? If it is chronic, look at the reticulocyte count. If it is really high, like 10, 20%, then these are the conditions. Hereditary spherocytosis, so these will be discussed in the subsequent talks. And if it is normal, then these are the conditions: thalassemia, alpha thalassemia, or CDA, which could be the differential diagnosis. So last few slides, causes of anemia below 6 months of age. So what is important to remember is that the deficiency anemias are uncommon in this age group. So typically one sees them after 6 months of age. So blood loss during delivery, isoimmunization, it can linger on for a little longer. Malaria is getting rarer in Iran now. Thalassemia is unlikely in this age group, typically after 4 to 6 months of age. So it could be either a CDA or a pure red cell aplasia. So when we see children in our emergency or OPD with anemia and bleeds, the differential diagnosis are acute leukemia, ITP, or aplastic anemia, anemia with bleeds. So how to distinguish between ITP or leukemia? Ask yourself the following 3 questions. Is there presence of hepatosplenomegaly or lymphadenopathy? If yes, it is leukemia, but it may not be present. So bone pains, is the child limping? Does he have backache? More likely to be acute leukemia. Hemogram, in leukemia, the WBC count may be low, high, or even normal. In DLC, always differential count, look at the lymphocytosis, because these could just be blasts which have been read as lymphocytes by the Coulter. So this was leukemia as well as and in aplastic anemia, there will be no hepatosplenomegaly and there will be pancytopenia on the peripheral smear. So my 20 minutes are done, so I will end here. Thank you so much for the invitation. Thank you.
Thank you, Dr. Deepak, for this amazing lecture. I wanted to thank you again for joining us and for sharing your knowledge again, and also for, as I said in our peer recording session, the amount of effort that you put into your slides and sharing the information from Iran as well as India and globally. So it was really interesting for me as a pediatrician. So I just wanted to thank you again. Thank you for joining us. Thank you for sharing your knowledge with us. And I hope you stay with us till the end of the session. So if there's any questions in the chat section, we will ask them after that. So dear Mahia.
Thank you, dear Mariam. Hello, dear Professor Bensal. So many thanks for your joining us. It made me so excited when I saw the name of our breads, Barbary, Sangak, during your slides. Thank you very much for your effort for mentioning our country during all your points of view. So many thanks for joining us. We are going to have 5 distinguished lectures in this session, so we are a little in the lack of time. We will have the Q&A session, discussion session at the end of the session, and we will continue with Dr. Srinivasan Peyam.
Yeah,
Dr. Srinivasan Peyam is a consultant in pediatric on hematology oncology. His areas of interest are childhood leukemia, late effects in childhood cancer survivors, pediatric sarcomas, and brain tumors. He is assistant professor of pediatrics, postgraduate Institute of Medical Education and Research, Chandigarh, India. Welcome, dear Professor Peyam. Thank you for joining us live, and such a great honor for our Congress to have lecturers such as you between us.
Thank you, Dr. Peyam, for joining us. Can't wait to listen to your lecture.
Yeah.
Thank you.
So is my screen visible? Am I audible?
Not yet.
Is my screen visible?
No. Please share your screen. You're co-host, and you can share your screen. Please choose the share screen on the taskbar below your screen. That's okay. Please full screen it. That's okay. Let's go on.
Yeah, thank you. So good evening, everyone. So today I'll be talking on difficult anemias. So I'll be focusing on a few cases. So the topic is like thinking out of the box. If you actually see, most of the diagnoses are like within our reach, and with the careful history, clinical examination, and schematic approach, we can diagnose majority of the anemias. However, there are a handful of cases which cannot be diagnosed, and for which we need novel diagnostic techniques, which includes genetics and NGS. So coming to the talk, so as we all know, anemia is a finding and not a diagnosis by itself. And anemia is not equal to disorder of hematological system always. It can be a manifestation of other systemic diseases as well. So one have to evaluate to identify the possible etiology and treat it. So the whole of the approach to anemia, as we all know, it depends upon the few factors. Like if it is, first of all, one has to see whether it is anemia isolated, or is there any other platelet or leukocyte abnormality as well. So if there is other cell lineage involvement, so one might need to go for bone marrow examination also to look at the etiology. So if the child is having only isolated anemia, then one has to look at the other RBC indices like MCV. So based on the MCV, so it is categorized into microstatic anemia, normostatic anemia, or macrostatic anemia. And one has to look at the bone marrow response, whether the bone marrow is adequately responding to the degree of anemia. So accordingly, we have to categorize into high reticulocyte anemia or low retic anemia. So with this careful approach, we can diagnose most of the cases. However, a few cases remains challenging to the clinicians. So before going to the out of the box, what are the common things inside the box? So these are some of the common diagnoses that we come across in our everyday practice, which includes nutritional anemia, the commonest, being iron deficiency anemia, followed by megaloblastic anemia, then beta thalassemia syndromes, sickle cell anemia, hereditary spherocytosis, G6PD deficiency, and autoimmune hemolytic anemia. So often the diagnosis is established without much difficulty in all such case scenarios. So now let's see few case scenarios. So here we have a 7-year-old boy who presented with a progressive pallor for last 12 months, who required 3 packed red cell transfusions till date and 2 episodes of epistaxis in the last 2 months. However, he did not have any fever, skin rash, jaundice, or recurrent infections, no other significant history. So clinically, we have a child who's having anemia as well, and also bleeding in the form of epistaxis, that is 2 cell line involvements. So with a careful clinical examination, like in this child, if you could see, he has a dysmorphism in the form of inverted triangular facies, and you can see he's having hypertelorism with epicanthal folds and cephalate spots and long tapering fingers. On an examination, he had pallor, and if you see his growth, it is grossly altered. So he's having underweight and height for his age. So the case questions here, it remains pretty simple, because we have on good clinical examination, we can see a few physical findings, which points towards probably the underlying inherited bone marrow failure syndrome, probably Fanconi anemia. So the blood investigation revealed anemia, leukopenia with the neutropenia and thrombocytopenia. And if you see the reticulocyte counts, these are like on the lower side. And if you see the RBC indices, the M series on the higher side. So we are having a microstatic anemia with a low retic count. So if you follow the same approach, because here we have other cell lineage involvement, the bone marrow can clinch the diagnosis. In the absence of it, if the child is having some stigmata for inherited bone marrow failure syndrome and child has only anemia, then one has to look at the indices. So in the current child, if you see the child has microstatic anemia with a low reticulocyte count. So these are the possible etiologies, which includes aplastic anemia, inherited bone marrow failure syndrome, which includes a Fanconi syndrome and dyskeratosis congenita, or other causes like Diamond-Blackfan anemia. So in this child, we went ahead with bone marrow, which is showing grossly hypocellular marrow with a overall cellularity of 10%, with a reduction in all three hematopoietic lineages, which is consistent with aplastic anemia. The diagnosis was further confirmed with the chromosomal breakage analysis, which are showing the clastogen-induced increased breaks in T lymphocytes and fibroblasts. So the inherited bone marrow failure syndromes are actually characterized by bone marrow failure, which is evident clinically in the form of cytopenias and physical anomalies, and they have inherent cancer predisposition. So these are some of the clinical features which most of us would have read in Nelson textbook of pediatrics. So which will show some of the clinical stigmata where one has to suspect underlying inherited bone marrow failure syndrome. So often we see childs presenting with some skin manifestations like capillary spots or simply short stitches. So careful clinical examination is of paramount importance. Having said this, so 1/3 of the cases may not have many physical anomalies posing a diagnostic challenge. In all such cases, so one may have to go for other diagnostic modalities like genetics to confirm the diagnosis. So coming to the case 2, we have a 9-month-old boy, asymptomatic till 2 months of age, and subsequently he developed progressive pallor and requiring 2 packed red cells. No other positive history. So again in the examination, if you see carefully, the child is having dysmorphism in the form of snubby nose with a long philtrum and having bifid thumb. And his growth is also altered in the form of weight and height, which are less than -3 Z-score as per WHO standards. And an examination, he has pallor and no organomegaly. Again, the case questions with careful clinical examination, it becomes pretty simple. Inherited bone marrow failure syndrome, the probable diagnosis could be Diamond-Blackfan anemia in this child. So the investigation confirming the child is having anemia with preserved other cell lineages and low reticulocyte count. And if you see the RBC indices, the child is having macrocytic anemia. So again, we are dealing with a child, an infant who is requiring transfusions and single lineage involvement with the macrocytic low retic anemia. So that if you follow the algorithm, so you'll end up having these differential diagnoses. So in our index case, probably Diamond-Blackfan anemia. So we went ahead with bone marrow examination, which are showing myeloid erythroid ratio of 90:1. Typically, it is 1.2:5:1. Here you can see that is a significant erythroblastopenia, which is very much consistent with pure red cell aplasia. So the important here is any child who is presenting with anemia involving only single lineage, and if you are not able to find any organomegaly, look up for the subtle signs of physical stigmata of underlying inherited bone marrow failure syndrome, like the anthropometry, which may yield microcephaly or low weight, low height, and dysmorphism, and other features like cleft palate or high arch palate and short or web neck, and typically the physical anomalies of the long bones of the forearm and thumb, anomalies like bifid thumb, triphalangeal thumb, and flat thinner eminence. So suspect Diamond-Blackfan anemia, especially in a child presenting in the infancy with macrocytic anemia with reticulocytopenia and bone marrow showing paucity of erythroid precursors in the form of erythroblastopenia. So coming to the case 3, so we have a 3-year-old male who presented with pallor for last 1 year with no other complaints except for intermittent loose stools. The dietary history is satisfactory, and an examination, the child was having pallor except for that unremarkable findings. If you see his anthropometry, again here the growth is further. So case questions. So one may think, if you're not aware of other few conditions, that it is probably a nutrition anemia because the child is presented with pallor, nothing significant on examination, it was a good nothing. So in the investigations, in the complete blood count, the child was having anemia, thrombocytosis, and low retic count. If you see the indices, these are microcytic, hypochromic anemia with elevated RTW, and peripheral blood film showing a lot of red cells with microcytic with severely hypochromic cells, and there are pencil-shaped cells which are very much consistent with the iron deficiency anemia. So this child was initiated on iron supplements at 4 mg per kg per day. However, there was no much response, or there is only modest response to the oral iron supplementation. So the complete blood count done after 6 weeks was showing anemia, which is again 5.4 gram per dl. So what are the clues to the diagnosis? Are we actually dealing with iron deficiency anemia or that it's something else? So the child had clinical peyam, however, if you calculate, the child represented with loose stools, and the anthropometry, the child was showing growth failure. Laboratory parameters are very much consistent with IDA, however, there was poor oral response to oral iron therapy. So are we having iron deficiency anemia where the child is constantly losing blood, or the child is having underlying celiac disease? So whenever we are having poor response to oral iron supplementation, these are some of the important factors that has to be considered and corrected before thinking of anything else, like poor compliance, intolerant to iron, inadequate dose, or other causes. If these are corrected, then do additional labs and then think of these diagnoses like celiac disease, beta thalassemia trait, occult blood loss, which could be from gut, or could be urine, or could be lungs, or iron refractory iron deficiency anemia, or other causes. So typically the beta thalassemia trait will not present with so much of low anemia. So in this child, we went ahead and did HPLC, which was normal, and stool for occult blood was done thrice, which was also normal. However, the serology for celiac disease and endoscopy cleans the diagnosis that the child was probably having celiac disease. So if you don't correct the underlying thing, like if you're exposing the child to the gluten-based diet, then the child will be having anemia despite iron supplementation. So coming to the case 4, we have 7-year-old female having pallor for last 12 months. So which was initially sudden onset and was gradually progressive. This child required 4 rectal transitions in the last 12 months. However, in between, the child was transiently improving and was responding to the hematinics, and the growths were preserved. On examination, the child had pallor, no icterus to point towards the hemolytic anemia or hemolytic phases or any other physical anomalies to point towards underlying inherited bone marrow failure syndrome, and no organomegaly. So the possible things could be here aplastic anemia or IBMF or pure red cell aplasia consisting only single lineage involvement and multiple transfusion requirement. Or it could be simply iron deficiency anemia with some occult blood loss going on. So because of the acute onset and the recurrent transfusion, these are some of the differentials. However, the child did not have any cross match difficulty to point towards autoimmune type of etiology, and child presenting at 7 years without any evidence of other ineffective erythropoiesis like hemolytic phases or organomegaly rules out thalassemia syndromes. So in the complete blood count, we can see the child is having anemia and thrombocytosis and low retic. Again, if you see the indices, it is microstatic hypochromic anemia, and peripheral blood film is typical of iron deficiency anemia. So if you follow the algorithm again, we have a child with microstatic anemia with a low retic. The probability are iron deficiency, beta thalassemia syndrome, cerebrosplastic anemia, lead poisoning, copper deficiency, etc. So what are the clues to the diagnosis in the current child? So if you see the child has pallor, which is chronic, however, the growths are preserved in this, unlike the previous child, where the growth was altered, and the laboratory was consistent with iron deficiency anemia, intermittent response to oral iron therapy. So we are thinking whether the child was having any blood loss on the occult sides. Meanwhile, we try to rule out the other etiologies that we considered. The HPLs are normal, ruling out the beta thalassemia syndromes. Despite iron supplementation, there was some response in between. The ferritin was in the borderline range, and serology for celiac disease was negative. And we did a stool for occult blood and urine for hemosiderin and RBC scintigraphy to look for any occult sites of bleed, which are all negative. And ANA was also negative in this child. So because we couldn't find any etiology, bone marrow was done, which was showing only erythroid hyperplasia, indicating a good bone marrow response to the. So meanwhile, the child presented to the ER room with a low-grade fever, severe pallor in the second month of follow-up, having mild cough and tachypnea. On examination, child had severe pallor and crepitations. We are probably thinking it could be seizure secondary to severe anemia. However, you could see that chest X-ray was showing ground glass opacities in the bilateral lungs, indicating probably the etiology could be diffuse pulmonary hemorrhage. So we went ahead with bronchoscopy and BAL, which are showing hemosiderin-laden macrophages. So probably could be pulmonary hemocydrosis. Too early to label it as idiopathic, but we did some of the investigations like ANCA and anti-GBM, which are all negative. And sometimes because the immunological mediated disease could be seen in celiac disease. Celiac has to be ruled out in all such cases, which was also negative. The child was started on oral prednisolone at 1 mg per kg, to which the child has responded. The anemia started improving. So coming to the other case, we have an 8-year-old boy who was having progressive pallor since 2 years of age, that is for the last 6 years. He required 6 packed red cells till date, that is 1 per annum. Associated with easy fatigability, no other positive history. So the child didn't have any birth history, which was such of any neonatal jaundice or blood transfusions, and no significant family history of any hemolytic disease. He is fourth in birth order, with other sibling was clinically normal. In the examination, the child had pallor, and if you see his growths, again he's having moderate wasting and moderate stunting, and it's showing the features of chronic malnutrition. However, there is no icterus or hemolytic in phases or physical anomalies to point towards any other inherited bone marrow failure syndrome or ineffective erythropoiesis. On examination, he had hepatosplenomegaly. So we have 7-year boy with anemia with hepatosplenomegaly. So what are the possible things that one should consider? So chronic hemolytic anemia. So first and foremost, that has to be ruled out, especially in the settings, is beta thalassemia syndromes. Other etiologies, though they can present with chronic hemolytic anemia, the absence of jaundice clinically rules out, and sickle cell anemia, because the child did not have any pain crisis previously, presenting only with anemia and transfusion, which is something odd for sickle cell disease. So other disorders could be congenital dyserythropoietic anemia or storage disorder, especially non-neuropathic variant of Gaucher's disease. So we went ahead with investigations, which are showing anemia. If you see the platelets and TLCs were within the normal limits, and the anemia was microstatic hypochromic anemia. And there are multiple reticulocyte count. The correct reticulocyte counts were on the lower side, like 2% and less than 2% in most of the occasions. And peripheral blood film was showing most of the occasions also anisopoikilocytosis with a lot of microcytes with moderate hypochromia, which was not pointing towards any particular etiology. So the serum biochemistry was not showing any evidence of hemolysis, like LDH was not raised, there was no unconjugated jaundice here. The HPLC of the parents and the index child was normal, ruling out the beta thalassemia syndromes here. And celiac serology was negative, and G6PD and direct Coombs test was negative in this child. So if you follow the algorithm, the child has anemia with a microcytic and low retic. However, the peripheral blood film was not very characteristic of iron deficiency anemia, and child had organomegaly requiring multiple transfusions. So we are dealing with one of these etiologies where we have already ruled out the beta thalassemia syndrome with HPLC. So other differentials could be here sideroblastic anemia. So bone marrow examination, when one has to consider bone marrow examination in a setting of anemia. So it will be rewarding in the setting of chronic anemia with low reticulocyte counts, like in our index case, and other scenarios like congenital dyserythropoietic anemia, sideroblastic anemia, aplastic anemia, or inherited bone marrow failure syndromes. So in this child, if you see that it's a male child with a chronic pallor requiring multiple transfusions. On examination, he had hepatosplenomegaly. Most of his complete blood counts are microstatic hypochromic to normochromic, low retics. Our HPLC was normal and slightly increased ferritin. That he has received 6 transfusions, but his ferritin was quite slightly high, indicating that there could be some amount of ineffective erythropoiesis going on. So we went ahead with bone marrow examination, which was normocellular. However, on the Pearl stain, we could see that the child, the bone marrow showed 60% ring sideroblast, confirming the diagnosis of sideroblastic anemia. The same was confirmed with genetic analysis as well, which are showing mutation in the 9th exon of ALAS2 gene, indicating it is X-linked recessive sideroblastic anemia. So that typically the management of sideroblastic anemia involves anemia and management of chelation and genetic counseling, and all the children should be initially given at least a pyridoxine trial and blood transfusion for infrequent transfusions. For refractory transfusion requirement sideroblastic anemia, hematopoietic stem cell is the curative option. So in this child, we initiated the child with the oral pyridoxine, initially at 50 mg per day. Later, it was increased to 100 mg per day. So in the last contact, he did not require any blood transfusion. And he was continued on chelation with defereserox and other supplements with folate, vitamin D, and calcium. So coming to another case, we have a 5-year girl with a progressive pallor from 3 years of age, presented with easy fatigability and no transfusions till date. No other positive history. She is a first in birth order with no significant birth history, that is no neonatal jaundice or any blood transfusion or any extended transfusion. She is a vegetarian and with no positive family history of any hemolytic anemia. And her growth parameters also well preserved. And on examination, she had pallor, she had spleen. So if you carefully listen to the other session, so the triad of hemolytic anemia would be anemia, unconjugated jaundice, and organomegaly. So here we didn't have any clinical jaundice. So these are the possibilities that are considered, like chronic anemias with ineffective erythropoiesis in view of the anemia and organomegaly, It could be chronic hemolytic anemias. However, clinically, they look very less likely because the child did not have any clinical jaundice, though we didn't do any lab parameters as of now. The other parameters could be nutritional anemia, but it should not have such as big spleen or blood loss anemia or systemic lupus erythematosus. So we entered with the investigations. The complete blood counts are showing anemia with without other cell lineages. And if you see the correct reticulocyte count, they were like normal to mildly elevated reticulocyte counts. And in peripheral blood film, that was showing occasional spirocytes as well, apart from the normocytic cells with a few microcytes. And in the serum biochemistry, you can see the child has mild unconjugated jaundice with the raised LDH pointing towards that there is some amount of hemolysis going on. And this is a peripheral blood film showing this. There are a lot of normocytic cells, and occasionally you can even see spirocytes. This where it was confusing because there are a lot of spirocytes also found in various peripheral blood films. So if you follow the approach, we have anemia, and we have an normocytic anemia, and we have low to slightly increased retic counts. So the etiologies could be anything here. This is the pitfall of reticulocyte. So whenever we are having different reticulocyte given by different filters, one has to go for manual retic count and confirm the reticulocyte count, which will sometime narrow down your clinical diagnosis. And as pointed in the previous session as well, this is a simplified approach for any child with hemolytic anemia. If you have unconjugated jaundice, see whether the child is having acute or episodic hemolysis or chronic hemolysis. In our child, the child is probably having some chronic hemolysis or low-grade hemolysis or erythropoiesis, and one has to look at the retic count, which will guide you further. So here we have normal reticulocyte count to slightly elevated reticulocyte count. So these are the possibilities considered. Though there are some high reticulocyte counts, these possibilities cannot be ruled out completely. So in the investigations, if you see, the nutritional anemia was little ruled out, and your HbHPLC was normal except for mild elevation of HbF, and HS was ruled out with the normal EMA, and G6PD was ruled out with the normal, which has done on multiple occasions. And your H-body inclusion hemoglobinopathies, which were also ruled out with the negative H-body inclusion test and heat stability test. So if you see effectively, your chronic hemolytic anemia was almost like ruled out, and beta thalassemia syndromes were also ruled out. So we went ahead with bone marrow examination in this child because the child was having normocytic anemia with the reticulocyte count normal to mildly elevated. So which is showing normal hypercellular with erythroid hyperplasia with a lot of this erythropoiesis in the form of binucleation and multinucleation. You can see here binucleated erythroid precursors, which is consistent with congenital dyserythropoietic anemia, which was confirmed with genetic analysis as well. The child was showing homozygous mutation in example of SEC23B gene, confirming the diagnosis of CDA type 2. So again, the management involved management of anemia, chelation, and genetic counseling, and the child may require infrequent blood transfusion. So unlike in other types of congenital dyserythropoietic anemia, CDA type 2 will respond to splenectomy if the child is transfusion dependent. So in this child, the child was initially not requiring any transfusion, but subsequently the child has become transfusion dependent. So the child was offered splenectomy, and currently she is off blood transfusion in the last contact, and continued on chelation therapy with the deferrasub and iron folate supplements. So coming to the last, I will quickly take to the last case scenario. We have a 4 months old male. He's a discordant twin, born to a non-consanguineous parentage. He had pallor since birth and jaundice in the neonatal period, and the jaundice were as high as 30 milligram per DL, requiring exchange transfusion for the jaundice. And his hemoglobins were like as low as 4.3, 3.4 on multiple occasions, requiring multiple red cell transfusions. However, there was no any family history of hemolytic anemia. On examination, he had pallor, he had icterus, and hepatosplenomegaly. So we are dealing with probably here a hemolytic anemia, probably be inherited because the child had very significant neonatal history with the NHA requiring exchange transfusions and subsequently multiple blood transfusions. So these are his investigations. He had anemia with without other cell lineages, and his retics were high. And if you see the biochemistry, the child is having unconjugated jaundice with the raised LDH values indicating the hemolysis and elevated plasma and urine hemoglobin. So these are his peripheral blood film, which was normocytic to normochromic with few target cells and polychromasia, and reticulocyte counts at multiple occasions were on the higher side, like 6%, 9%, and 6%. So if you follow the algorithm again, the child is having isolated anemia, and this MCV is normocytic with high reticulocyte on most of the counts. So the etiologies could be membranopathy, angiomyopathy, or other hemoglobinopathies like unstable hemoglobinopathies. If it is like acute, it could be autoimmune hemolytic anemia or HUS-CTP spectrum of disorders. So in the supplement approach, if we follow again, the child has unconjugated jaundice with a chronic hemolysis, requiring multiple transfusions with high reticulocyte count. Again, if you look at the various possibilities, these are hereditary spherocytosis, pyruvate kinase deficiency, unstable hemoglobinopathy, or autoimmune hemolytic anemia. So in this cell, these are the possibilities considered, and the investigations are showing a normal HPLC except for elevated HbF, and your direct contrast rules out any autoimmune hemolytic anemia. Typically, autoimmune hemolytic anemia that we see in children is acute. So very rarely we come across chronic autoimmune hemolytic anemia. And your osmotic fragility test and EMA test rules out your hereditary spherocytosis, and G6PD and glucose phosphorescence is done in this child, which are also normal, ruling out G6PD deficiency. And other investigations like HPH inclusions and heat stability test was also performed, which are all normal, ruling out your antibody inclusion disorders like unstable hemoglobinopathy or alpha thalassemia. So we could luckily get pyruvate kinase enzyme in this child, which was slightly on the lower side. So possibility of pyruvate kinase deficiency was considered. This child, because was transfusion dependent, he underwent initially partial splenectomy because he was 1 year 10 months at this age. Subsequently, following splenectomy, his transfusion requirement has come down. He received only 4 in the last almost like 2 odd years. So later we got a genetic diagnosis, confirming the diagnosis of pyruvate kinase deficiency. We can see the child had mutations in PKLH. So this child was continued on folic acid supplementations and infrequent blood transfusions and chelation therapy, and plans to do total splenectomy once he is more than 5 years of age. So the crux here is, so one has to meticulously look for the clinical examination, positive physical findings, and lab parameters. So consistently, one has to look at the various lab parameters like MCVs and reticulocyte on multiple occasions, which will narrow down your differential diagnosis. Thank you.
Thank you, Dr. Peyam. Oh, go Bhatia.
Thank you very much, dear Dr. Peyam, for a nice presentation, and thank you, dear participants, for participating in the chat section, asking your questions. Please do not hesitate to ask your further questions, and so many thanks to dear Dr. Jain and Dr. Bensal for answering the questions. If you agree, we will continue the session with dear Dr. Richa Jain, and we will answer all other questions if necessary at the end of this session in Q&A part. Dr. Richa Jain is medical doctor in pediatrics, pediatric hematology, oncology, and associate professor at Pediatric Hematology Oncology Unit, Department of Pediatrics, Chandigarh, India. Dr. Richa Jain has more than 10 years of experience in the field of pediatric hematology and oncology. She has 50+ international and national publications in her areas of interest. She has authored 15 chapters in the most popular textbooks in her field, and she has received multiple awards for her research at international and national conferences. Hello, dear Dr. Jain.
Hello, Maya. I'm very pleased to be here. Thank you very much for the invitation. I hope you can hear me.
Yeah. Hi, Dr. Jain. Hi.
Hi.
Thank you for joining us. We have your voice clearly. And also thank you for answering the chat section. Awesome.
It's a pleasure to be here. Actually, I have close friends and family from Iran, so it has a very special place for me, definitely. And I'm very happy to be here. So
have you been in Iran as well yourself?
I've never been, and I look forward to visiting.
You should visit your family members here, you know.
I should.
We would love that. We would love to have you here as well. Thank you for joining us.
Thank you. Hope to see you in person soon in Iran, dear Professor Jain. And now we are with you, and I'm sure we are going to have a nice presentation and an educational one. Thank you. Let's start.
Thank you very much. Is my screen visible?
Yes, dear Professor, it's okay.
So I will be talking about microstatic hypochromic anemia beyond iron deficiency. a lot of some of what I am going to talk about has already been covered by Professor Deepak Bensal and Dr. Srinivasan. So I will skip over those slides which are talking about the same things. So Dr. Bensal talked extensively about the iron deficiency state. And if with the persistence of iron deficiency, people evolve from pre-latent iron deficiency to latent iron deficiency to frank iron deficiency. And while the pre-latent iron deficiency has a normal hemoglobin, let me just get the pointer. So the pre-latent iron deficiency has normal hemoglobin, but the tissue iron stores are depleted. And this condition is picked up only if a serum ferritin is done for some reason and it is low. And whereas the latent iron deficiency, there is a beginning of anemia, and you see decreased serum iron as well as decreased serum transferrin receptor, and a very sensitive new indicator, which is the reticulocyte hemoglobin concentration, which is available in some of the automated pool tests these days. This is very sensitive. This picks up this latent iron deficiency easily. Whereas frank iron deficiency, as we all know, is associated with low hemoglobin, frank microcytosis, as well as hypochromia. So I think this graph has also been shown previously that world over in children, iron deficiency anemia is a problem. In India, it's more than 40% of the children are iron deficient below 5 years of age, but it's a problem even in Iran, with about 25 to 30% of the children having iron deficiency. We have also talked about the treatment of iron deficiency, 3 milligram per kg per day of single dose. The 6 milligram dose is no longer considered to be required for plain simple nutritional iron deficiency. The duration is typically 3 to 6 months. With oral iron, ferrous salts are preferred over the ferric salts. We are very used to writing this treatment, this prescription in our day-to-day clinic practice. But sometimes it happens that we see children with microstatic hypochromic anemia who just do not respond to oral iron. So when does iron not work? So typically 10 to 15% of the children with microstatic hypochromic anemia, after we have excluded obvious causes like thalassemia major and thalassemia intermedia, which cannot be possibly confused with iron deficiency, there will still be these percentage of children left who do not really respond very easily to iron. So, and they are called iron refractory. Who are these children and how do we define iron refractoriness? So the definition of iron refractoriness is appropriate oral iron therapy of 3 milligram per kg per day has been given for at least a period of 4 weeks. And there is a lack of appropriate response, which is the rise of hemoglobin remains less than 1 gram per deciliter at the end of 4 weeks of this therapy. Then these children are labeled as iron refractory. So what are the causes of these iron refractoriness? This is what I'll be focusing on, including the genetic causes here. So coming to the causes, first, as mentioned by Professor Bensal, compliance is a big thing. Lack of compliance, incorrect formulation like ferric salts or carboxymaltose or some similar sounding other drug maybe have been given, an incorrect dose may have been given after we have checked the compliance. We should check for ongoing losses. Meckel's diverticulum, worm infestations are important causes in children. Inflammatory bowel diseases are less common. Inflammatory bowel diseases are less common, whereas menstrual losses are typically seen in adolescents. Pulmonary causes, as shown in the last presentation, with idiopathic pulmonary hemosiderosis, urinary losses with Berger syndrome, and even rarer is hereditary hemorrhagic telangiectasia. So for us, Meckel's and worm infestation are the leading causes. And further coming to inadequate absorption, celiac disease is a very important cause. Again, 2 to 3% prevalence is seen in the general population in Iran, and it's very common in our country as well. So whenever we have a child with iron deficiency anemia who is not responding very easily to oral iron, we always make it a point to do the tissue transglutaminase antibodies to rule out celiac disease. At times, endoscopy is also required. Helicobacter pylori infection has also been associated with inadequate absorption, but this is typically seen in a slightly older age group as opposed to a very young age group. Chronic proton pump inhibitor treatment with omeprazole or ranitidine leading to a high gastric pH or bariatric surgery are typically problems seen in the older age group and very infrequently seen in the pediatric department. After this, we have to deal with alternative diagnoses of microstatic hypochromic anemia, some of which include a thalassemia crate or a thalassemia minor, a sideroblastic anemia, chronic diseases like chronic kidney disease, inflammatory diseases, and autoimmunity, which would lead to a state of relative iron deficiency leading to a microstatic hypochromic anemia. Once we have run through that list of causes, we come to this relatively recent group of disorders, which are the genetic disorders of iron absorption or utilization, which are known as IRIDA, iron refractory iron deficiency anemia. So I would like to discuss a few cases here, and I'll start with the first case. So we had this patient, Master J, who was a 6-year-old boy who presented to us with complaints of progressive pallor, noted by parents since the age of 1 year. So in the detailed history, he had a blood transfusion at the age of 1.5 year locally. However, in the negative history, there is no history of passage of worms in stool. There was no history of perianal itching. There was no history of pica. His diet was a normal mixed diet. So this helped us rule out the plain simple nutritional iron deficiency on the history. There was no history of diarrhea. There was no history of GI bleeds. There was no history of recurrent infection. And with this, the possibility of celiac disease and meckel diverticulum were a bit reduced, though not entirely ruled out. And the other chronic illnesses and immunodeficiency were also less likely at this point of time. There was no history of jaundice or abdominal distension, making hemolytic anemia less likely. No other cell line involvement, no significant family history. In the birth history, the treatment history, as I mentioned, birth history was uneventful. The treatment history at 1.5 years, he had required a transfusion at a hemoglobin of 7.1 gram per deciliter, and he had been intermittently on oral hematinics. The dietary history was unremarkable. So we investigated the child when he came to our center. On the examination, the child had, the only significant finding this child had was pallor. There was no hemolytic facies, no jaundice, skin bleeds, edema, or lymphadenopathy. Anthropometry was normal. There was no organomegaly. So we were possibly dealing with a non-syndromic anemia, likely an iron deficiency anemia or a mild hemoglobinopathy. And the investigations confirmed severe anemia. His hemoglobin was only 7.7 gram per deciliter when he came to us. The RBC count was near normal. Reticulocytes were reduced for the degree of anemia he had, and the MCV and the MCH were very low. MCV was only 61, MCH was 17. And this was confirmed on the peripheral smear, where we had severe microcytosis and hypochromia along with poikilocytosis. The platelets were quite elevated, which also made us think of iron deficiency, because thrombocytosis is often seen with iron deficiency anemia. The differential counts, the total counts were normal and remain normal. The renal and liver functions along with C-reactive protein was normal, which ruled out a lot of chronic illnesses and infections. We gave him oral iron, but at week 6, his response was quite suboptimal, and hemoglobin only rose from 7.7 to 8.1, which was not adequate. The rest of the parameters remained the same. So at this point, we were wondering whether we are dealing with the iron refractory anemia. He definitely met the definition. We had ensured compliance. So we set out to rule other causes before we decided to evaluate for the genetic cause of IRIDA. And at this time, we still were working with reasonably broad diagnosis of some form of iron deficiency or an associated thalassemia crate. Unusual causes of microstatic hypochromic anemia like sideroblastic anemia and genetic IRIDA kind of an anemia. So our investigations showed stool for occult blood was negative 3 times. Meckel scan was done, which was negative, and tissue transglutaminase antibodies were negative, ruling out celiac disease and Meckel's diverticulitis. HbA1c was normal. In fact, the HbA2 was on the lower side, which is often seen with the iron deficiency. So this ruled out thalassemia trait. An iron study was done, which was remarkable for the degree of iron deficiency this child had. His serum iron was low, his TIBC was quite elevated, transferrin saturation was very low, and serum ferritins were also much below the normal. So at this point, we also reasonably have ruled out sideroblastic anemia, which is associated with transferrin saturation, and ferritin are both elevated in this sideroblastic anemia. So with this kind of a situation, we went ahead with the genetic diagnosis for IRIDA, And before I show you the results of the genetic diagnosis for IRIDA, I will just talk briefly about IRIDA. What exactly is IRIDA? It's a rare form of inherited iron metabolism defect, which was first described nearly 40 years ago in 3 siblings who had persistent microstatic hypochromic anemia, poor response to oral iron, and partial response only to the intravenous iron therapy. However, the causative mutation took nearly 30 years from this point of time to be discovered. And we found that gene on chromosome 22, the TMPRSS gene, is involved in the pathogenesis of this disease. More than 40 mutations have been described till date, and it has been thought at this point that the inheritance is autosomal recessive. So it codes for matriptase 2, which cleaves hemojuvelin. Here we come to hepcidin, which was asked in the chat box. So hepcidin is a key regulator of iron homeostasis in our body. So with this mutation in TMPRSS gene, hepcidin is consistently upregulated in our body, and the liver overproduces hepcidin. There is overproduction of hepcidin because it's not destroyed. And hepcidin works on 2 forms. One is in the GI and the other is in the spleen. In the GI, it works to decrease in the duodenum, it decreases the absorption of iron. Simultaneously, it also decreases the release of iron from the splenic RES cells. And hence, with this bifold mechanism, the plasma iron concentration decreases, leading to anemia. So this is an inappropriate response, inappropriately elevated hepcidin to the degree of iron deficiency. In general, when there is iron deficiency, the hepcidin levels are quite low to promote iron absorption from the gut. So here we are looking at inappropriately high levels of hepcidin as related to the degree of iron deficiency that patients with IRIDA have. So the classical phenotype of IRIDA is clinically we see moderate anemia with severe microcytosis is present. MCV may be as low as 45 to 55 or 60 femtoliters. Typically, patients have minimal to no transfusion dependence. There is no phenotypic abnormality seen, and family history may or may not be present because often IRIDA is ameliorated with age and older people may not manifest with severe anemia. In the lab parameters, the serum iron is decreased, the transferrin saturation is decreased, which is seen in our index case here as well. The ferritin is typically on the lower side, but maybe within the normal range, the lower normal range as well. Hepcidin levels are inappropriately high, and transferrin saturation is to hepcidin ratio is typically quite low. The caveat here is that while the serum iron, transferrin saturation, and serum ferritin are easily available to most of us in our day-to-day clinical practice, hepcidin level is typically available only for research purposes. It is not available for most centers. And in fact, a population nomogram is required because the hepcidin levels vary from population to population, as well as they are variable between different age groups like infancy, childhood, and adulthood. So in the absence of population nomograms and availability of hepcidin levels, these tests are mostly for research purpose only. So the diagnosis is more easily established by mutation analysis in the when there is a phenotypic IRIDA profile. The treatment, these children typically show a minimal response to standard oral iron therapy and a partial response only to parenteral iron therapy. So how do we treat these children? We are primarily dealing with the main mechanism here is because of increased hepcidin, decreased intestinal mucosal iron uptake. To bypass this, what makes the maximum sense is giving parenteral iron treatment. So as mentioned in the prior 2 talks, ferric carboxymaltose, ferrous sucrate, multiple preparations are available, which are very safe and easy to give, but they have to be given multiply. A single dose would not suffice because this is a genetic problem, and these children would continue to have high hepcidin and reduced gut absorption of iron. So an alternate treatment, which we have seen would work occasionally, is high doses of oral iron with vitamin C, 5 to 6 milligram per kg per day, given in 1 to 2 divided doses with up to 30 milligram per kg of vitamin C, which enhances the iron absorption, has been seen to be effective in some percentage of cases. In fact, in a study from our institute, we found that a significant proportion of children with mutation-proven IRIDA responded to this therapy. Oral iron alone is less successful in treatment of these children. So when we see the treatment response to iron, the serum ferritin levels typically show a sequential increase after IV iron. Hemoglobin improves. Typically, microcytosis would improve variably. However, transferrin saturations remain low and hepcidin levels remain high. Parental iron is typically required in children who have non-response or suboptimal response to oral iron. And however, response whether to parenteral or oral iron is variable, prolonged, and repeated therapy is often required. So coming to the index case, we did a mutation analysis by NGS for evaluation for IRIDA. The NGS will be dealt with in the subsequent talks. And we came up with the, a compound heterozygous state for mutation in the TMPRSS6 gene. A compound heterozygous basically means there were two different mutations inherited from the father and the mother. So this child had a compound heterozygous, which was consistent with the diagnosis of genetic diagnosis of iron refractory IDA. This was the profile. The father had a heterozygous mutation. The mother also had a heterozygous mutation, which were both pathogenic. And the child, unfortunately, had inherited both the genes and was a homozygous for this mutation, a compound heterozygous leading to IRIDA. So how did we treat this child? We gave him parenteral iron. There are various formulae available. We used this one. And we saw a remarkable response, which was very gratifying. The hemoglobin shot up from 8 grams per deciliter to 14. And however, as you can see, the MCV remains borderline for this particular child. The MCH also remained on the lower side. The platelet counts had reduced and come back to normal. So this child continues to be on follow-up and requires parenteral iron every few months. And he's doing well as far as growth and development is concerned. So this is just a diagnostic algorithm that we follow. The norms of hemoglobin are well known to everybody. When we see microstatic hypochromic anemia with low HP with no obvious cause like thalassemia or blood loss, then we typically think of iron deficiency anemia, especially as our population has a lot of iron deficiency. And we treat with oral iron without investigating further, just based on the CBC and our kind of setup. And typically a rise in hemoglobin confirms the correct diagnosis, and we continue with the completion of therapy and dietary counseling. However, if we see a failure of response at 4 weeks, then we do investigate further and look for all the causes which I had outlined earlier, and poor compliance, inadequate iron doses, GI causes, other chronic diseases. And then we look for mutation analysis for IRIDA after doing the appropriate preliminary investigations. So coming to another illustrative case, we had a 2-year-old boy, again, early presentation, as you can see here, relatively early in life, presented with moderate persistent anemia detected by the pediatrician. He had a primarily vegetarian diet, but no other significant history, no bleeding. Examination was unremarkable except for pallor. And the hemoglobin was low. It was a moderate anemia with a hemoglobin of 8.6, low reticulocytosis, severe microcytosis, and hypochromia, as can be seen here, which was confirmed on the peripheral smear. And again, he was a non-responder to oral iron at 6 weeks. The hemoglobin just did not budge at all, 8.6 gram to 8.8 gram. So we further evaluated all the other causes, HPLC, celiac serology, GI bleeds, chronic diseases were all ruled out, and iron profile again confirmed severe iron deficiency anemia, and a mutation analysis was done for this particular child. And you can see here that this child had a splice site mutation. He was a homozygous for this particular hotspot mutation, which in fact causes iron refractory IDA even in its heterozygous form. So this child definitely had IRIDA, and we tried giving him oral high dose iron with vitamin C, to which he responded only partially. Subsequently, he required parenteral iron, after which his hemoglobin has increased, and now he remains on follow-up. Coming to a third case, which is slightly different. He was a 7-year-old boy. So you can see the difference in the age of presentation. This fellow was slightly older with an onset of disease at 5 years of age, again with progressive pallor. However, his pallor was severe, his development and growth was normal, and his diet was exclusively vegetarian. His hemoglobin was 5.6, as I mentioned. Again, severe microcytosis and hypochromia. Ferritin was absent practically. The TIBC was elevated. The transferrin saturations were very low. Another thing here was that his B12 levels were also quite low. And the bone marrow also showed absence of ring sideroblast, ruling out sideroblastic anemia here with dual deficiency anemia. He also had B12 deficiency anemia along with the severe iron deficiency. Iron stores were absent. The pearl stain in the bone marrow was 0. So the NGS report was a bit of a surprise. We were expecting that we would get a plain simple homozygous or a compound heterozygous IRIDA. However, we found heterozygous polymorphism on a single exon, which is not, if you think of it as an autosomal recessive disorder, then this should not cause such a severe disease. So however, this kind of mutation has also been linked with the iron refractory phenotype of IDA, which is partly responsive to oral iron. We treated this child with B12 supplementation and gave him high doses of oral iron and vitamin C. At this point, he has improved. His ferritin has also improved slightly, and he continues on oral iron prophylaxis. So at times, patients who are heterozygous may also manifest with phenotypic IRIDA is the important thing. So this is like an evolving field where we are seeing that this is the gene for TMPRSS gene. And while most of the mutations are cause phenotypic IRIDA only when there are either autosomal recessive homozygous or they are compound heterozygous. However, there are certain mutations at the splice site here that you can see, and certain other mutations, frame shift mutations, which may lead to which may lead to IRIDA even when this is a haploinsufficiency. So a single gene inherited may also lead to this. I think I'll just very briefly touch upon IRIDA homozygous versus heterozygous as we are running short of time. So phenotypic IRIDA, now that we know, we observe this in heterozygous patients as well. Females seem to be more affected than males. This may be because they have other causes as well of iron deficiency, diet, menstrual losses, etc. Symptoms are seen to ameliorate with age, possibly because the period of rapid growth children are also likely to have more features of iron deficiency. So typically, patients with homozygous IRIDA would have an earlier presentation as compared to heterozygous IRIDA, more severe phenotype. The transferrin saturation is to hepcidin level would be very low as compared to not so low, though still low. And it's not very clear at this point whether parenteral versus oral iron therapy would be more effective, but mostly parenteral therapy at this point is considered to be the therapy of choice. That is what we end up giving in the majority of our patients. And I think that I will stop here because we are quite short on time. And to conclude, I will just say that 10 to 15% cases of microstatic hypochromic anemia in the clinic are iron refractory. The common causes like celiac disease, the GI bleeds, associated thalassemia trait, and chronic disease need to be ruled out before we do mutation analysis for unusual diseases like IRIDA and sideroblastic anemia. The IRIDA phenotype would be very recognizable from the clinical as well as the laboratory point of view, with very low transferrin saturations and very low serum ferritins. The NGS would help in confirming this rare diagnosis, and the treatment is with parenteral iron, and at times oral iron may be attempted along with vitamin C. So I will stop here and just stop sharing my screen here. So thank you very much for patient listening.
Thank you, dear Dr. Jain, for your educational lecture. That was really useful for me as a pediatric resident of pediatrics. Thank you, and thank you, dear Professor Trehan, for answering the questions in the chat section. We are going to continue in lab investigations, the newest updates by dear Dr. Bhatia.
Thank you.
Dr. Prateek Bhatia is a postgraduate in pathology and has done his doctorate in pathology in 2005 from Peyam, Chandigarh, India. He is in charge of pediatric pathology laboratory, including pediatric hematology oncology molecular laboratory, Peyam, Chandigarh, India. He has about 100 plus publications in national and international journals to his credit. And he's Associate Professor of Pediatrics, Postgraduate Institute of Medical Education and Research, Chandigarh, India. Dr. Prateek Bhatia is Diplomate of Royal College of Pathologists and Certified Hematologist, certified genomic data scientist from Johns Hopkins, USA. Dear Professor Bhatia, I see your name during the participants. Hello, and thank you for accepting our invitation. We are going to share your pre-recorded video, and if we had any questions, we will ask you at the end of the session at Q&A part.
Yes, dear Mahia, I will play the pre-recorded version of Dr. Bhatia's lecture because he privately sent a message to me that he had a not unstable internet connection. So
Okay,
I will play that.
Thank you so much.
Dear friends, thank you for this opportunity to present at your esteemed Congress. I'm Dr. Prateek Bhatia, Associate Professor in Pediatric Hematopathology and Genomics from PGIMEA, Chandigarh, India. Today I'll be talking with you on laboratory investigations in anemia. I have no financial competing disclosures to make. We've seen this slide over and time again in this session on any difficult anemias. Basically, this slide tells about the classification of anemia based upon the underlying pathophysiological mechanism, be it hematopoietic disorder, increased degradation, blood loss, or distribution disorder, or based on the morphological classification that's microcytic hypochromic, normocytic normochromic, or macrocytic hypochromic. And these are the common etiologies which underline we also in our routine clinical practice know that there are certain basic tests which we have to do for diagnosing anemia, and these basic tests primarily involve a complete blood count, including a peripheral blood film examination, a retic and a correctic retic count, iron supply studies, and in certain cases marrow examination. But important among these are the hemoglobin, the mean cell volume, red cell distribution width, the PBF findings, and the corrected retic, which will in most cases guide us towards certain specific tests in anemia. And these specific tests could range from HPLC to vitamin B12 folate levels to a DCT or G6PD screen or to flow cytometry for PNH. So there's a vast gamut of investigations which can be done for a diagnosis of particular case of anemia. But in today's lecture, it won't be possible in the limited time to cover all these investigations. The aim of this talk would be primarily to look at certain new or novel markers which have come up over the last few years and aid us in diagnosis. Especially, are there any rapid markers to pick up or define iron deficiency or iron deficiency anemia in a setting of anemia of chronic disease? How to pick up latent or pre-iron deficiency? How to define functional iron deficiency? Are there any quantitative markers for TMA? How to work up and detect inherited iron-related anemias, which is usually a neglected topic? And what is the role of hepcidin or erythropoietin as biomarkers in anemia? So the current talk would focus on some of these areas and look at what investigations are there which can aid us in diagnosis of anemia in these settings. So let's look at this slide. We all know that iron profile which we order primarily comprises of serum iron, total iron binding capacity, transferrin saturation, and ferritin levels. But we don't usually know is that all of these tests within iron profile do have certain limitations. Their serum iron has a marked diurnal variation with variation in levels during the morning and evening hours, and serum iron is much more affected with a recent iron rich diet or with recent iron therapy. So once you have these levels, you have to know in what particular context you have ordered them and you are interpreting these levels. And serum ferritin, as we all know, is an acute phase reactant and is likely to be elevated in acute or chronic inflammatory conditions, and it becomes difficult to look at iron deficiency or iron deficiency anemia in such settings using serum ferritin alone. Moreover, these markers are very slow responsive markers to therapy evaluation, and we need or we require certain markers which can tell us about utilization or availability of iron at the cellular level and in a much rapid time. So another terminology which we usually are not very well versed is functional iron deficiency or iron restrictive erythropoiesis, where the stainable bone marrow iron within the macrophages is available or present, and ferritin levels are usually within the normal range, but iron somehow is not available for erythropoiesis. That is, the iron is not going to the bone marrow to the developing erythroblasts for normal erythropoiesis. And this usually happens in conditions like acute anemia of chronic disorders due to infections, inflammatory or malignant disease, where there's increased cytokine levels which block the recycling of iron, resulting in a state of functional iron deficiency. It's also very commonly seen in cases of chronic kidney disease who are given erythropoietic stimulating agents like EPO. These agents lead on to a sudden demand of iron which cannot be met, resulting in a functional iron deficient or iron restricted erythropoiesis. Now, serum transferrin receptor was one test which became a very fancy test over the last decade when it came, and it basically detects the soluble or the truncated form of transferrin receptors in the plasma. Basically, transferrin receptors are expressed in increased amount on the developing erythroblasts and capture the transferrin bound iron. So they basically reflect the body's demand for iron and are a more accurate measurement of the iron availability in the developing erythroblasts in the bone marrow. So they are usually increased in IDA the levels and are unaffected by inflammation. So they are very helpful in differentiating between an iron deficiency anemia and anemia of chronic disorder. And we usually have heard that a ratio of serum transferrin receptor to log ferritin, if it is more than 2, suggests that there is a concomitant iron deficiency along with anemia of chronic disorder. However, this test did not become a very routinely ordered test, since it's usually done by ELISA method, and you require samples in batches to be processed, and so it's quite technically laborious, and samples run in batches result in delaying in reports, and overall it's a relatively costly test to perform, and there are no international standards or standardized method yet available for reporting of this test. Certain rapid new parameters for iron deficiency anemia and anemia of chronic disease differentiation, and these new markers are available from current automated CBC or hematology analyzers. And two common markers are percentage hypochromic cells and reticulocyte hemoglobin concentration. They are known by different names in different automated hematology analyzers. For example, if you look at percentage hypochromic cells, it's also termed as hypo-HE in Sysmex analyzers, and reported as LDH or low density hemoglobin in Bachmann-Coulter analyzers. Whereas your retic hemoglobin concentration is reported in Sysmex XC as reticulated hemoglobin equivalent or RET-HE, and in Bachmann-Coulter by red cell size factor. It was first given by Siemens hematology analyzers and was available as mean concentration of reticulocyte hemoglobin. These markers are now rapidly available. So you can use the same EDTA sample for which you run for a routine CBC, and you can get the report for these markers from the automated hematology analyzers. However, one has to remember that the sample needs to be processed within 4 to 6 hours so that the results can be interpreted. Now, if we have a look at these markers in a little detail and look at their clinical utility in different scenarios. So first of all, let us have a look at reticulocyte hemoglobin concentration. Now, this is a reticulocyte hemoglobin is a marker which tells us about the availability of functional iron for erythropoiesis over previous 2 to 3 days, because we know that reticulocytes take a time of maturation of around 2 to 3 days in the peripheral blood. So they give us an immediate information about the availability of iron over the last 2 to 3 days. So they are an acute marker of availability of functional iron in the bone marrow, and they increase within 2 days of iron therapy. So it's an important marker and is now being routinely recommended for use in various guidelines for management of anemias, especially in patients with CRF. It also has a good correlation with serum transferrin receptor and bone marrow iron staining. The normal levels for ret hemoglobin range from 28 to 35 picogram, with the following cutoffs. If less than 25 picogram, it's usually suggests functional iron deficiency, and if less than 22 or 23 picogram, it suggests classical iron deficiency. Ample literature now available to support the use of this marker in clinical practice. If you look at this study, which was done way back in 2005, and it clearly shows that this marker reticulocyte hemoglobin is much helpful in differentiating the anemia of chronic disease as well as IDA from the reference group. So in the reference group, you have the level somewhere between 33 to 35, and in ACD cases, it drops down to 28 or 29, below which you suggest functional iron deficiency. And if an ACD case has an iron deficiency or there is iron deficiency per se, the levels would fall below 23 picogram. So this marker is also now a part of the guidelines, as I told before, for evaluation of anemia in CRF patients. And rather, it has been mentioned that a target, reticulocyte hemoglobin more than 29 picogram is in the guideline for iron assessment in percentage hypochromic cells, also termed as low density hemoglobin, is also a sensitive marker of availability of iron, but there is a slight difference between this marker and the reticulocyte hemoglobin. Basically, percentage hypochromic cells is looking at the number or the percentage of red blood cells which have hypochromia. And because red blood cells have a lifespan of around 120 days, so this is a marker of chronic iron deficiency and or availability of iron to the developing erythroblasts in bone marrows. So it suggests your state of iron deficiency which has been persisting over the last 2 to 3 months. And it's a sensitive marker and increases before there is any change in MCHC even. And hypochromic red cells, basically defined as hemoglobin concentration less than 28 gram per deciliter. In the healthy population, the percentage of hypochromic red cell usually does not exceed 2.5%. But if it goes beyond 2.5%, the person does have functional iron deficiency or an iron restrictive erythropoiesis state. And if it's more than 6%, he has classical iron deficiency anemia. There's also different algorithms which are now available, especially incorporating both this reticulocyte hemoglobin and percentage HRC to look at, to guide us about the iron therapy in CKD cases. This is from the BCHS guideline 2013 on functional iron deficiency. So a case of chronic kidney disease, you get these markers done. And if they are, your retic H is less than 30.6 or the CHR done from a Siemens analyzer is less than 29 picogram and your percentage hypochromic cells are more than 6%, you look at the serum ferritin levels. If serum ferritin are less than 200 μg per liter in a hemodialysis case, or less than 100 μg per liter in a peritoneal dialysis case, it suggests classical IDA in CKD case and patient does need intravenous iron. However, if serum ferritin is between 200 to 800, still it's a state of functional iron deficiency and intravenous iron is recommended, and there would be improvement in the hemoglobin if you give intravenous iron along with EPO in such cases. On the other hand, if we summarize these two markers and look at the clinical utility in clinical practice, so they are able to differentiate between an IDA versus anemia of chronic disorder, that is between actual versus functional iron deficiency, and these are the cutoffs as I defined earlier. They also help us in looking at the response to iron supplementation, also in anemia of chronic disorders, and also help us in assessing need for parenteral iron substitution. As I told you in the last algorithm on CKD cases, they are also sensitive early predictor for response assessment to iron in general. Rather than looking at retic after 2 to 3 weeks of therapy with iron, one can look at these markers after 4 to 5 days, and they'll give us good information about the availability of iron to the developing erythrocytes and some improvement whether the iron is being available to the bone marrow and improvement is expected or not in the. So coming to another marker which is available from automated hematology analysis, this is the immature reticulocyte fraction. It is a quantitative measure of immature retics, and it gives us an idea about the direct cellular measurement of erythropoiesis. So basically, we all know that reticulocytes contain mRNA which is yet to be shed, and which they rather mature over a period of 2 to 3 days in the peripheral blood. So the more the more premature the retic is released from the bone marrow under stress conditions, the more higher is the immature reticulocyte fraction. It is nothing but the sum of the moderate to highly fluorescent retics when you stain them with a fluorescent dye. So there will be three population of reticulocytes which can be evident here. So low fluorescent reticulocytes, medium and high fluorescent. So basically immature reticulocyte fraction in hematology analysis is the sum of medium to highly fluorescent reticulocyte, and it's available in the following CBC or automated hematology analyzers available. The normal ranges are a little wide, but one can remember that IRF normal range varies from 2% to around 18%. One has to remember again that these markers, if need to be interpreted in the right context, the sample needs to be processed within primarily the ANC, the reticulocyte count, and the HFR component of immature reticulocyte fraction, that is highly fluorescent retics if above 5%. The study was further able to suggest that the patients, if the HFR was more than 5%, the recovery usually this suggests a recovery if this levels rises 5%, and the recovery time one can see is quite earlier as compared to other markers like ANC or reticulocyte count. The median time for a rise in HFR is around 13 days after infusion in comparison to retic or ANC, which usually rise 19 or 18 days after a bone marrow transplant. To this, there is also guide for interpretation of IRF and retic together in certain conditions. So if you have parallel rise in your retic as well as IRF count, it suggests either an acute hemolysis or blood loss. If you have quite depressed retic and IRF counts going in parallel, it suggests a bone marrow failure or sort of a plastic anemia picture. However, if you have a discordant sort of normal or reduced retic but a slightly higher IRF, there is discordant between the two values, then it suggests either megaloblastic anemia or MDS. If you have a reduced retic or a normal IRF, it suggests an iron deficiency anemia or anemia of chronic disorder. However, retics, if are markedly increased as compared to IRF, it suggests hereditary spherocytosis, since this is a membranous abnormality, and the more premature or retics are unstable, so the IRF fraction is not high, but the retic fraction is relatively post bone marrow transplant or chemotherapy. It starts to rise 5 to 7 days and reaches a peak around 10 to 14 days. Helps us in monitoring renal transplant engraftment, monitoring neonatal transfusion needs, monitoring anemia therapy response, especially B12 and folate, and monitoring EPO therapy in cases with renal failure, AIDS, or so another marker, which is a quantitative measure of the degree of the amount of fragmented red cells and is quite helpful in TMA or thrombotic microangiopathic conditions, is a fragmented red cell count. So this is also available as an automated marker from different hematology analyzers, and basically we can see here that the fragments are distinctly separate if from the red blood cells, and basically this separation is based upon the volume of these particles as well as their refractive index, and this is a basically 100% sensitive marker. So if you need to rule out presence of TMA and the levels of this percentage FRC are less than 0.5%, you are nearly 100% sure that the patient does not have at least TMA, but it has low specificity. So if the levels are high and go beyond 1.5%, so you may not be sure whether this case is a true TMA case, or it could be due to presence of other red cell abnormal shapes or poikilocytes, and one has to look up at the peripheral blood smear. So this was a study which we performed in a typical as well as other hemolytic uremia syndrome pediatric cases, and what we found was that this a marker has a sensitivity of 95.4% for a cutoff value of more than 1.5 and an accuracy of around 85.7%. And we concluded that percentage FRP can be used as FRC can be used as a rapid and highly sensitive index for screening of pediatric HUS. However, a peripheral blood film examination is must in cases wherein the count is more than 1.5 to 2%, so as to avoid false positives as the index has low specificity. So one can, any suspected case of TMA, one can, if it has thrombocytopenia and an FRC count is more than 1.5 or 2%, especially for term baby, or more than 5.5% for preterm baby, one can look at the peripheral blood film to see or rule out other red blood cell changes or poikilocytes. If other poikilocytes are present in significant number, then one should think of other possibility rather than TMA. However, if schistocytes are the dominant finding, along with maybe some polychromasia, reduced platelet count, or NRBCs, then TMA is usually. So the clinical utility of percentage FRC is in diagnosis, rather exclusion and follow-up of microangiopathies like HUS, TTP, and DIC, in disseminated carcinomas, transplant-associated thrombotic microangiopathy, and the normal reference range, as I told, is around 0.03 to 0.58%, but a little higher in preterm. So, and now moving on to another topic, anemias, which is usually neglected and not thought of, is atypical microcytic hypochromic anemias. So how do we define them? So once we know that the common causes of classical microcytic hypochromic anemia are iron deficiency anemia, thalassemia, or anemia of chronic disorders. But sideroblastic anemia and other iron related inherited anemias usually do not come in our differential. So these conditions are what are termed as atypical microcytic hypochromic anemias, and if we try to classify them, we can classify them as defects of iron transport or uptake, which includes conditions like hypotransferemia, DMT1 mutations, or STEAP3 mutations, which are basically carriers of iron absorption at the enterocyte or required for acidification of iron within the developing erythroblast. Defects of iron absorption, which is termed as IREDA, or defects of iron recycling, under which comes the acelloplasminemia, or they could be sideroblastic anemia disorders, which could again be X-linked, autosomal recessive, or some polysyndromic types. Now, we started around 5 to 6 years back looking at these atypical microcytic anemias. Our hypothesis then was, are we missing or underdiagnosing these inherited anemias, because our country is basically a country where iron deficiency in 2 to 5 years old children is quite endemic. So any child which is coming in 2 to 5 years or 6 years age or even later, the usual suspicion with microcytic hypochromic anemia is IDA, and most of the time these conditions are usually not thought of. So we might be missing these conditions if we are not following a structured approach of testing or looking for these conditions, and that is what we to develop in our setting. So let's have a look at a case. It's 8-month-old female child who presented with history of transfusion outside for anemia 1 month back. On examination, she had pallor and her HB was 6.3 gram per deciliter. She had severe anemia. Antenatal history was she'd received a transfusion for hemoglobin for 8 gram per deciliter at day 23 of life, which was outside. Thereafter, HB had risen to 11.5, but no reports were available with us. Her current indices were microcytic hypochromic with an MCV of 58 and a retic count of 1.8%. So looking at this picture, we also thought that she did not have any organomegaly to add out here. So we thought of we'll need to rule out basically hemoglobinopathy disorders, because these are also quite endemic in our setting. So we did a HPLC, and we also looked at a CBC and peripheral blood film examination. So the PBF here shows quite a bit of anisopoikilocytosis. We can appreciate the presence of basophilic stippling and an occasional NR. So the test performed further was an HPLC, which was negative. We also did an alpha-thal sequencing, which was also negative. We also ruled out any sort of hemolysis by doing an LDH, which was normal, and plasma and urine hemoglobin, which were negative. Thereafter, we performed an iron profile. So serum iron was 180 and ferritin was 880 mg per liter, and transferrin saturation was 46. Now looking at this ferritin, it is quite elevated, even considering that the patient has had 1 or 2 transfusions prior. So there is discordance in the ferritin levels, even if we consider that the patient has transfusion, so it's relatively high, and the TSAT was high. So taking both this into account, we thought of a sideroblastic anemia, and we ordered a bone marrow examination, which revealed around 78% Rick sideroblast on Pearl stain. So considering this, it was quite evident that the patient now has congenital sideroblastic anemia possibly, and we need to perform genetic studies to identify the gene. So we have a custom-made panel for inherited iron-related anemias, which covers genes for sideroblastic anemia, for also for near iron metabolism-related proteins, and for iron overload proteins. So we performed this using this panel. We performed the targeted NGS on an iron torrent S5 platform, and we can see here a multinucleotide variant, which is a complex variant but homozygous in nature, resulting in a stop codon at this particular location in SLC25A38 gene. Now, this gene is basically protein is basically responsible for glycine transport within the mitochondria for the first step of heme synthesis. So, mutation in this particular protein results in autosomal recessive form of congenital sideroblastic anemia, which usually presents with severe anemia in birth, and which is usually transfusion. With this case, what conclusions which can come off is that we need a particular structured approach to look at atypical microcytic hypochromic anemia. So in our clinic, we follow these approach. We try and look at iron profile in cases which usually do not appear to be classical iron deficiency anemia clinically, and then work them up structurally by certain biochemical tests. A guide to this is, if you perform an iron profile and you find a high serum iron and high serum ferritin, especially if these iron markers are discordant to the amount of or the number of transfusions received, then one should work them up further. So if they are both elevated, serum iron and serum ferritin, one should perform serum transferrin levels, and if they are very low or undetectable, one should think of a transferrinemia. However, if they are normal, one can do a bone marrow examination to look for ring sideroblasts. And if they are more than 15%, one knows that it's usually a congenital sort of sideroblastic anemia. So if no ring sideroblasts are seen, one can still work them up genetically to rule out conditions like DMT1 or STEAP3 mutations. However, if you have an other side, you have an iron profile where the serum iron is low, but serum ferritin is normal or high, and you have ruled out acute anemia of chronic disorder or inflammatory conditions, you can look at serum ceruloplasmin levels. So if you are absent or undetectable, you might be looking at a ceruloplasminemia, and if they are normal, one should try and look at hepcidin levels and rule out IRIDA, which is due to TMPRSX defect. Following this guide, what particular clinical and laboratory pearls which can keep in mind when we approach atypical microcytic hypochromic anemias are that any neonate or infant who presents with microcytic hypochromic anemia with or without transfusion requirement, one can suspect these disorders. All of these conditions except IRIDA usually present immediately after birth. SLC25A38 is usually a transfusion dependent and severe form of autosomal recessive sideroblastic anemia. The rest types are usually mild to moderate or have a variable degree of anemia. Any history of microcytic hypochromic anemia in siblings or family members must be sought for, and one should especially look for any male siblings being affected to rule out query X-linked sideroblastic anemias, which are much more common. Indices are usually disproportionate to degree of anemia in IRIDA. Other microcytic hypochromic anemia conditions must be ruled out, especially thalassemia by HPLC or alpha gene sequencing, and celiac disease by TTG and ACD by CRP if one is suspicious of IRIDA. So this has been well discussed in the last slide by my colleague. So refractoriness to oral iron should be to at least 2 different oral iron preparations before labeling IRIDA. Iron profile in all cases should be done. At least one should have a serum ferritin and serum iron levels, and then interpret them with caution if the past blood transfusions have been received. So you should look at discordant ferritin and iron with respect to number of transfusions. And you should work them up further if you have an atypical iron profile. An atypical iron profile is basically if the patient has high iron and high ferritin despite transfusions, or despite or disproportionate to the number of transfusions, or if he has low iron and normal to high ferritin levels. So further structural testing is based upon this iron profile, and you may require transferrin, ceruloplasmin or hepcidin levels as I showed in the algorithm on the previous slide, and even a bone marrow examination. Lastly, molecular testing helps us develop. If you do a targeted panel testing with genes which cover the sideroblastic anemia and other iron metabolism proteins, then you can pick up a mutation in these particular cases with atypical iron. Another interesting topic which has come up now is the role of hepcidin and erythropoietin as biomarkers for anemia. So before we go into that, let's have a look at briefly at what is the erythropoietin, hepcidin and iron axis. So if we look at this figure here, so when in a state of normal erythropoiesis, when there is normal oxygen tension, the basal levels of EPO are released, which help in development of erythroblasts in the bone marrow, and these developing erythroblasts secrete normal levels of erythropoietin, which is a hormone. This hormone acts on the liver cells and reduces the hepcidin secretion to a certain extent, so that the absorption of iron can be little bit increased for the developing erythroblasts. So this is all in a normal hemostatic state. But what happens when there is anemia with effective or ineffective erythropoiesis? In both conditions, there is increased release of erythropoietin by the developing erythroblasts. But in cases of ineffective erythropoiesis, because more of the developing erythroblasts are dying within the bone marrow, the levels of erythropoietin are much more higher as compared in a state of effective erythropoiesis. So these highly markedly elevated levels of erythropoietin in ineffective erythropoiesis state block hepcidin markedly, resulting in a marked increased absorption of iron at the enterocyte level via pyropoietin channels. This results in iron overload, sort of increasing your NTBI or the non-transferrin bound iron fraction, which can then indirectly result in end organ damage, especially to liver, spleen, pancreas, and other organs. So there is also classification which is now coming up based upon the hepcidin levels, and you can look at low hepcidin anemias or high hepcidin anemias. And low hepcidin anemias primarily include iron loading anemias, especially seen in anemia with ineffective erythropoiesis, that is different hemoglobinopathies, especially beta thalassemias, congenital dyserythropoietic anemia, sideroblastic anemia, where there is a lot of destruction of developing erythroblasts in the bone marrow. So the levels of erythropoietin are markedly increased, and these suppress the hepcidin levels. So the hepcidin levels are quite low. And high hepcidin secreting anemias primarily include, acquired, especially are more common, especially when there is underlying acute or chronic inflammatory disorder. And hereditary, we know, is the IRIDA, where there is a defect in the TMP RSS and high secretion of hepcidin. Even hepcidin producing adenomas have been described in glycogen storage disease 1A. So hepcidin has some role, especially in classification of these anemias. So hepcidin is a 25 amino acid protein and is secreted as a precursor by the liver, and it acts by internalization and degradation of ferroportin at the enterocyte and macrophage level. The normal levels are 20 to 200 nanogram per ml. However, there is no international standard method available yet. Two most common methods by which hepcidin can be estimated is ELISA and MS, and we'll see a little later, done briefly. The main indications for hepcidin testing now in anemia primarily is as a marker of iron dysregulation to differentiate ACD and IDA. So in a case of ACD, you'll expect your hepcidin levels to be elevated due to these cytokines, and in IDA it will be quite low. It can be a guide to iron supplementation therapy to predict EPO response, and also to diagnose acute kidney injury and monitor and assess as the use of EPO and other agents. So there are many targeted molecules now available for hepcidin in different trials, which are likely to come up for treatment for iron overload anemias, as well as for anemias wherein there is high hepcidin levels like IRIDA. So both hepcidin agonist and antagonists are being being looked at into different trials. Come back to the methods which are available or assays available for hepcidin. As I told, there's no international standard yet available, but the two common assays which are ELISA and MS. ELISA is usually commonly performed, but mass spectrometry is a much more specific, and the one has to remember that if one does a level of hepcidin by mass spectrometry, the levels are likely to be 3 times lower than that calculated by ELISA, but they are much more specific as they look at the active 25 hepcidin levels. ELISA kits for specific for 25 hepcidin active molecule are also available and should ideally be used. One also has to remember that the levels in children are relatively quite lower than as compared to adults. So as I showed that the normal levels of hepcidin vary from 20 to 200 nanogram per ml, but for children the levels are different, and we've described them in different studies that the normograms for children vary from around 2 to around 25 or 30 nanogram per ml. So they are around 3 times less than the adult levels. So one has to cautiously interpret hepcidin in different age groups in children, and these are few studies from our end which are available as a guide, but one has to establish normograms for hepcidin before one can interpret it in clinical practice. So with my lecture, and I would like to thank you all for this opportunity. And this is about our lab, the molecular as well as the routine hematology lab at PGME at Chandigarh. My thanks to all my staff there who help with the daily work and the molecular work related with our specialty. So thank you once again, and I'm open to questions.
Hello, dear Professor Bhatia. So many thanks for joining us, and thank you for your complete and knowledgeable lecture.
Thank you. My apologies for overshooting the time limit. So I'm sorry for that. So I thought that the topic was so vast and it was a little difficult to cover it in the 20 minutes. So my apologies for the time.
Thank you so much. Without further ado, as we are running out of time, we will go on the last amazing lecture of the session by dear Professor Trehan. Dr. Trehan is Professor of Pediatrics, Pediatric Hematology Oncology Unit, Postgraduate Institute of Medical Education and Research, Chandigarh, India. And also, she is member of the International Society of Pediatric Oncology and Associate Member of Children's Cancer and Leukemia Group of United Kingdom. Previously, she was co-chair of SIOP PODC Nutrition Working Group 2017 to 2019. Dr. Trehan is Executive Committee member of Pediatric Oncology in Eastern and Mediterranean countries, and the chairperson of Pediatric Hematology Oncology Chapter, Indian Academy of Pediatrics. Dear Professor Trehan, thank you for accepting our invitation. Thank you for gathering this amazing team to have a particular session for our Congress. Hello and welcome.
I would love to thank you, dear Professor Amita, as well. But thank you for. I know it's really late there, so
yeah.
I think it's actually midnight.
Okay.
So thanks for staying and thanks for joining us. We are more than eager to listen to your lecture.
Right. I'm just trying to open my screen.
And dear Professor, please consider the time because we are running. Thank you.
Yes,
thank you very much.
I know. I try and shorten it as much as possible.
I'm so sorry for what.
I'm just trying to figure out why my screen is not coming on.
So what seems to be the problem? So
I'm just it was there. Oh dear.
It's okay.
I think I have made a mistake somewhere. I've done something funny. Right. No. Just I'm really sorry. I know we're running out of time and just
no, it's totally okay. Don't rush it.
I'm not rushing. Just give me half a second. I agree with you.
For sure.
Yeah. It's okay. It gives people a little time to relax because they've been very busy and hectic for everyone. Yeah, I'll just log in again, Miriam. Okay, just half a second.
Yeah,
okay,
of course.
No problem.
I just did that, right?
We are all here waiting for your amazing lecture.
Oh, dear Dr. Trehan, you are a co-host now, and you can open your voice and your video.
So, Mariam, meanwhile,
am I there?
Yeah,
Yeah,
you're here.
Yeah, I'm so sorry. I don't know. There was some issue suddenly, and it just wouldn't let me share my screen.
no worries at all.
No, I know. It's kind of not nice when we're already got late. It's difficult. Yeah. So I just start to share. Yeah. Is that visible?
Awesome.
Yeah.
Yeah, that's okay.
Okay. Is that fine? So I apologize everybody for this little glitch, and I know everybody is getting a little tired, but and we are coming to the end of the session. But and I really thank Tehran University for giving us this for our unit, this opportunity. I'm privileged to present at your conference, which has an amazing session. So, the last session is next generation sequencing, the answer to all our anemias. So genomic sequencing has been around for a long time now, for nearly 2 decades. It started with Sanger sequencing, and then karyotype and NGS has now come up, which is of various type. It can be targeted panels, exome and genomes. There's a whole variety of it. We won't go into that. And Dr. Bhatia had sort of said it. And the new kid on the block now is going to be chromosomal microarrays. So now we look that, yes.
Sorry, dear Dr. Amita, sorry. So I think that your slides are not on screen, on full slideshow mode, and also they're not moving. Oh
dear. Is that okay now?
Yes.
Yeah.
It's much better. Yeah.
Something goes wrong in the middle of the day, end of the day. So with time, what has happened is that molecular genetics has become a sort of accepted part of everyday life. And why this has happened is that diseases are very heterogeneous in nature. There's a big gray phenotype which we see of disease, which has based on one gene, and it's like big shades of gray. You can be any shade of gray, but the disease is actually one. And this is what results in diversity of genomic alterations in Mendelian disorders. I just explained that a bit. So now, genome next generation sequencing was initially primarily just for research, and then certain clinical assays were established where it was found it's very useful. And the way things are going, it is soon going to become like standard clinical practice. Okay. Now, technology is a part of everyday life. We are very, very dependent on technology now. Look what happens if you don't have a telephone for an hour. Now, advances in science have been an inseparable part of human contribution to the welfare of mankind. And like one small step for man has been a giant step in mankind from the time man landed on the moon. Now, heterogeneous disorders, like I said before, are very difficult to diagnose. This is because heterogeneity arises because of various issues which occur. Now, what happens is that when it's heterogeneous, there can be a lot of things which happen. There can be change in the amount of genomic locus, which affects your clinical features. There can be changes in the structure and changes in the sequence. Any one of these results in problems, your phenotype, and that is why you can have a wide phenotype or a heterogeneous phenotype, which makes it very difficult to diagnose. So normally, how do we diagnose a patient? Traditionally, when we start, we are taught from all the time from medical school that you take a good history examination, you take a complete blood count, blood film, and then you go on to your bone marrow, morphology, etc., or an HPLC, DCT, electron microscopy, depending on what you need. And this is actually the gold standard routine workup in any hematological case. Now, all clinicians in the audience and all of us will accept the fact that a lot of times we are still unable to diagnose a patient. Okay. And then what do? It is said we wait and watch, we reevaluate after a few months, and the wait and watch continues, and sort of very often it just goes on. Okay. So this brings us to what happened, the need of next generation sequencing. Now, my colleagues have earlier said that yes, they've already explained that anemia is so vast. It's like a big cauldron, all the way from a simple nutritional anemia and to really, really complex anemias, which Dr. Jain and Dr. Bhatia mentioned. So it's really amazing, a huge things which can happen in just a small anemia, right? And when we use it in benign hematology, essentially it is used for inherited bone marrow failure syndromes, hemolytic anemias, bleeding disorders, and iron-related disorders are where it is most frequently used in this day and age. Okay. Now I'll just give you some food for thought. There was a 16-year-old boy who presented to us for a second opinion. He had been transfusion dependent since 2 months and had pancytopenia since 11 months of age. So a steroid trial was given, and at that time he had neutropenia and thrombocytopenia resolved, but anemia persisted. In addition, he had failure to thrive and an absent left kidney, and also was noted to have chronic diarrhea with increased fecal fat and fatty infiltration of the pancreas. Okay, so I will leave you all to think about this case for a couple of minutes. And we go on to the next case, which was a 9-year-old boy who presented with transfusion requirements since 4 months with no past history. He was absolutely well with a good weight and height. The blood counts showed pancytopenia. The marrow was hypercellular, suggestive of aplastic anemia. The chromosomal breakage was normal and no sibling match was found. So please start thinking about how you would treat this patient, and I just go back to the first one. So because of the clinical phenotype of cytopenia, a fatty sort of a diarrhea or chronic diarrhea, failure to thrive, and absent kidney, he was labeled as a Shortman-Diamond syndrome. But when we did the gene sequencing, no variants were seen. And interestingly, it turned out the child had a heterozygous variant in the RPS19 gene, which is the commonest gene involved in Diamond-Blackfan anemia. So the final diagnosis in this child was a Diamond-Blackfan anemia with pancreatic lipomatosis, right? So it fit in, but it was a simple Diamond-Blackfan anemia. Now the second child was diagnosed as aplastic anemia and given immunosuppressive therapy. Okay, the child got ATG and cyclosporin as immunosuppressive therapy, as a transplant could not be done. At 1 year of therapy, there was no response, and he continued to need blood transfusion. So at that time, the child had fever and an X-ray was done. Must have been done earlier, but this time the radiologist said that this child has rib and vertebral anomalies. So it was thought, oh dear, that something is wrong. So the child underwent next generation sequencing, and the diagnosis in this child turned out to be a Shortman-Diamond syndrome. So we can see that what has happened is that, one patient is thought to be something basically on your clinical and phenotypic features. And once you do further investigations, it turns out to be something totally unexpected or the reverse. Okay. Now, this child, I go over it fast because it's a little long. This patient is 19 and he has been symptomatic since 1.5 years, essentially with pallor, and he got 1 transfusion at 1.5 years of age. There was no other significant history at all. He got a transfusion at approximately every 1 year interval, and he came to us at 5 years. The only thing significant on examination was that he was short, his height was less, and so was his weight. There was absolutely nothing on examination. He was a well child. So the child had anemia. When he came, he had received a transfusion, so there was nothing except some microstatic hyperchromia. We followed him up and the hemoglobin fell with a poor retic response. Interestingly, he had macrocytosis and a bone marrow just revealed, it said more or less normal, and they could not give any comment. So at that point of time, we managed him as a case of pure red cell aplasia because it was only the hemoglobin which was dropping, and he responded well to steroids. We continued him on low dose steroids for a few years. After about 4 or 5 years, it was seen that the hemoglobin dropped again, and at that time his total counts dropped. And we repeated a marrow, and they said that this is just erythroblastopenia. So we were sort of confused that, oh dear, what are we dealing with? So then we worked him out further for other things: HIV, ANA, parvovirus, immunoglobulin, paroxysmal nocturnal hemoglobinuria, chromosomal breakage. It was all negative. And then we were breaking our heads. We repeated a marrow which said that this is hypocellular. Initially, the cellularity was normal. Then they said this is hypocellular. Okay. So then we observed the ANC over the next couple of years, and it was seen that the neutrophils remained in the range of about 800 to 1000, which meant that initially he had only a low hemoglobin, but now even his neutrophil counts were dropping. So we had a 19-year-old, anemia since early childhood, received transfusions maybe one every year, nothing on his investigations, nothing really on the marrow initially, and no other test negative. After having about 3-4 marrows in a period of about 10 odd years, it just said mildly hypocellular with nothing else, and the basic workup which we could do was all negative. So when NGS was available to us, we did an NGS which showed a TINF2 mutation consistent with the diagnosis of dyskeratosis congenita, which this mutation accounts for about 11 to 25% of DKCs, presents in early childhood, and aplastic anemia without physical anomalies in 2/3 patients, and can sometimes have immunodeficiency. So this actually illustrates that this child was evolving. He is obviously an inherited bone marrow failure syndrome, but he has evolved by starting with just a little bit of drop in the HB, and then with years he evolved. It took us so long to diagnose him, only when we had access to NGS. And before that, for 10 years, we kept sort of beating around the bush and trying our best. Okay. Now, this child is a little 6-year-old who came to us in 2018 with bluish patches, fever, epistaxis, weight loss. Examination had pallor, bleeds, lymphadenopathy, hepatosplenomegaly. Okay. At this point of time, in the past history, it was revealed that he had thrombocytopenia diagnosed 2 years ago. At that time, he was absolutely well. Someone thought he had a spleen tip, was not sure. He was thought to have ITP because he was 6 years old with just a little thrombocytopenia, did not get any therapy. His previous counts in 2016 just showed a little bit of thrombocytopenia. I mean, 66,000, and it sort of recovered. So it was thought that he had probably had ITP and recovered. Again, when he came in 2 years down the line, he had anemia, he had high counts, and there were blasts in the peripheral blood film. Okay. His bone marrow was done, which showed 26% blasts, and there was dysgranulopoiesis, hypolobulation, and it was diagnosed as an acute myeloid leukemia with preceding thrombocytopenia. Because he had preceding thrombocytopenia, it was molecular defects were looked for, and karyotyping, cytogenetics was done, and whatever was available to us turned out to be negative. So we were not sure why he had, whether the preceding illness could be related. So he received chemotherapy for AML, and however, unfortunately, the child had refractory disease, and we could not go ahead with any other definitive therapy. So it was felt that probably the child had a myelodysplastic syndrome 2 years, because of the thrombocytopenia, which evolved into an AML. But then we did the NGS. Again, this child had dyskeratosis congenita 1 gene positive, which is linked with AML and platelet disorders. So it was this defect which was playing up 2 years ago and evolved into a malignancy. Right? And so the bottom line remains, we were able to diagnose it and not battle that, okay, MDS, what is it, etc. So just a brief word. This has been mentioned earlier that we know inherited bone marrow failure syndrome is ineffective erythropoiesis, hematopoiesis, cytopenias. They have unique genotype and phenotype features, increased risk of progression to myelodysplastic syndromes and leukemia. And the most important thing is that longitudinal follow-up is important to monitor complex phenotype evolution, as I have shown in the couple of cases I presented, right? They are missed, okay? So we'll skip this. So the last case is a little girl who was 2.5 years or so when she came with symptoms which started at 1 year, 9 months. She received 8 blood transfusions in 6 months and 6 platelets. The child was born of a 3rd-degree consanguinity. She was the 3rd child. There were 2 deaths which were possibly unrelated to this child's illness. On examination, she was absolutely well, and the systemic examination was unremarkable. Her investigations done had shown anemia and thrombocytopenia. Interestingly, her MCV and her was high, and she had macrocytosis polychromasia C. Her iron profile, coagulogram, HPLC was all normal. The bone marrow showed normal normoblastic erythropoiesis and thrombopoiesis, but she has 26% ring sideroblast. The Pearl stain for iron was adequate. So again, when this child's mutation was done, she had an SLC 19A2 mutation, which is thiamine responsive megaloblastic anemia. And if we look what happened to this child, I mean, we won't go into how it presents, we don't have time. Then once we got this diagnosis, we started this little girl on thiamine in May 2021, which is about 7-8 months ago. Since then, her hemoglobin has been maintained and she has not needed any transfusion. If we had not been able to get this diagnosis without this investigation, we would still probably have been transfusing her and running around in circles. Okay. Now, it sounds very nice that, that NGS is good. And, when I've highlighted these cases, it sounds like, wow, we've been able to diagnose cases. Yes, we have. However, it still needs to be used with caution. You need pre-test counseling. We have to remember that when you're counseling a single gene, it differs from a whole exome sequencing, depending on the type you're using, targeted, the whole genome, etc. The patient has to be told. And the most important thing is that when you're screening, genes unrelated to the condition you're looking for will also get screened, because it's not possible just to pinpoint that area. And there's possible identification of healthy carriers of pathogenic variants will occur, which has implications for family on finding variants. Risk factors for another disease might be uncovered, which, may or may not be good. So one has to use clinical discrimination and discretion. So NGS outside research must be clinically indicated. You can't just go around doing it. So when a clinician orders it, you must know what to expect prior to the test. You can't just say, okay, let's get a whole genome sequencing done. It's fashionable, let's do it. And parental anxiety is not excuse. Yes, parents are apprehensive when you can't come to a diagnosis, but, we have to be very clear before ordering such a test like this. We have to be very clear what we expect to get out of it before just ordering it. Okay. So yes, NGS has revolutionized diagnostics. Okay. It has a total transformative effect. We can provide a diagnosis, and very often when we did not know. And once you have a diagnosis, you can prognosticate, which has, and therapeutic implications are obviously go hand in hand with the diagnosis. This is what is called a theranostic impact. Your therapeutics and diagnostics go hand in hand. And naturally, once you have it, you can have your treatment. It can be initiated, altered, postponed, or stopped, depending on your definite diagnosis. And it is a streamlined approach. It can possibly avoid unnecessary evaluation. We don't know what a patient has, You're calling them regularly 6 months, 1 year, 1.5 years, a few years go on, and we keep repeating marrows, we keep doing tests, hoping we'll get it. So possibly the future is going to be a genetic first approach. We don't know. Okay? We have to remember, do no harm. We serve to the best of our capacity, use the state-of-the-art method, and supplement standard diagnostic criteria. Yes, NGS is expensive. However, it instills confidence. You get the correct diagnosis, which results in correct treatment, and your patient's fear that I don't know my diagnosis gets allayed once you have a definite diagnosis. Of course, please, we have to remember that any test, there's nothing without challenge and pitfalls. Like I said, you have variations of unknown significance. Risk factors for other diseases get uncovered. We still do not know the whole gene. Every gene defect do not know. There's limited number. There's lots we don't know in this whole world. We didn't know anything about COVID until it's hit us 2 years ago. All this needs very sophisticated bioinformatics. Large storage capacity is needed. And as I said, there are ethical issues because, you know, in some other disease might get uncovered while doing this. You might find you have a variation which is going to affect you 50 years down the line, and you discover it when you're 10. So that can be a big problem, right? So I thank you all for a very patient listening. Thanks again to the university. And I apologize for that funny, I don't know what happened suddenly to the slide. Sorry. And I'll stop sharing.
Thank you, Dr. Trehan, for your time that you gave us. So many thanks for arranging this session for us. I know you are so busy, but the effort that you made for us, the time that you gave us, and the chance that you made for our Congress was really, really grateful. Thank you so much.
Professor Tehran, dear Amita, you are always a close friend and a dear teacher for all of us. And during these 2 years that we have been working, we have honored to work with you. You really touched our heart, and we are grateful for what you and your colleagues have done for us. I'm sure that the regarding what we have heard from our colleagues here, the topics was so exciting for them. And as you may know, the sessions will be accessible on YouTube forever. So this will be a continuous teaching, you know. And thanks to you and all your colleagues on behalf of a pediatric group in Tehran University of Medical Sciences. And I wish we will be honored to have you and your colleagues in Tehran very soon.
Thank you so much. And I'm sorry that the time overshot. It's though we tried our best, we really apologize for that. Yeah.
You are great.
Thank you so much.
Thank you, everyone. Thank you.
Thank you, everyone.
Thanks, everyone.
Thank you, everyone, for joining us. Thank you for staying with us. All the videos for today are recorded on YouTube channel of our Congress, Pediatric Webinars TUMS. And dear Iranian participants, do not forget to take the exam in order to receive your CME credit at the end of this session. Thank you. Good night, good morning, and good evening, all dear colleagues. Thank you.
Bye.